Three, two, one. We are live now, sir.
Good evening, everybody. Myself, Dr. Vishal Dave. I'm gynecologist and medical advisor to Intas Pharmaceuticals. On behalf of Intas Pharmaceuticals, I welcome you all for this 30th episode of Synergy on the topic Vaginal Surgery is Redefined. Before starting the webinar, we will have a prayer.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
It is my privilege to introduce Dr. Monica Singh. Dr. Monica Singh is President-elect of Bhopal OBGYN Society, Founder-President of ISOVAP chapter of Bhopal. She is National Executive Member of ESAR. She is Joint Secretary cum Joint Treasurer of MPIIG, and she is Coordinator of Foxy Infinity Committee. She was also convener of ESAR Perfection Series, Foxy Symbiosis Series, and the present, the Synergy Academic Club. Over to Dr. Monica Singh.
I am very thankful for the kind introduction, Dr. Vishal. Dr. Vishal Dave, along with Team Intas, they are the team which is supporting us in our academic ventures since the last 3 years. That is why, and with the blessings of all seniors and teachers and mentors, we have reached today the 30th episode. Our effort has always been to follow our mother institution, Foxy, and collaborate with as many societies as possible in order to make them feel all inclusive. And it is from these societies only that I pick up my guests and my guests of honor, my speakers. So it's very important. The cohesiveness is the backbone of Synergy. Today is the 30th episode of Synergy. We celebrated the 25th episode with great pomp and show, and that was an ultrasound webinar. Today we have selected a very good topic. Like Suman Sinha madam said, she is the chairperson of the Foxy Vaginal Surgeries Committee, a very dynamic and very hardworking chairperson, as well as a great surgeon herself. She has taken this committee to great heights with with her travel, with her talks, with her work, with her surgeries. And it was her brainchild that she suggested the series of talks and the speakers for today. Today, we are proud to collaborate with 11 societies of Punjab and 14 societies of Haryana. And we welcome the new 14th Society of Haryana today, that is Panipat. Our webinar, because of its collaboration with Foxy Societies, has been granted 4 ICOG points for whoever is watching it live. But for the benefit of those who miss watching it live, it is recorded on YouTube, and anybody can use the link to join to the YouTube channel and watch this webinar at the leisure of their homes and on a holiday. So we are going live now with Vaginal Surgeries Redefined on the 21st of May 2026 at Thursday. And I am very, very honored to welcome our chief guest for today evening, Dr. Jaideep Malhotra, madam. And madam will be joining very soon. Dr. Vishal, could you please tell Dr. Purva or Dr. Virul to place a call to madam once again for reminder?
Yes, ma'am.
Yes, ma'am, I'm calling.
Yes, please. Thank you. So till Jaideep madam joins, we will just walk through the program and then we will introduce our guests. So today we have a terrific lineup of lectures, and they are taking through the entire spectrum of vaginal surgeries. Instead of starting with the first talk, we will be starting with the talk on McCall's scaldoplasty by renowned Dr. T. Srikala Prasad, madam from Chennai, followed by the second talk on leaf-foot colpoclysis by Dr. Rajendra Saraugi, sir. The third talk is on modified Shirodkar cerclage by Dr. Uma Rani Swain, ma'am. And the last talk is by Dr. Hara Prasad Patnaik, sir, on NDVH after sir lands in Jammu, because he is in transit right now. So now let me have the pleasure of introducing our Foxy dignitaries for today. Mitra madam is right now in another program by ICOG, but she will be joining anytime soon. And Purva and Virul will keep me informed. But Suman madam has joined us right on time. And
Ma'am, Jaideep madam is joining.
madam is Okay, just tell me as soon as Madam joins and we will introduce Madam. So
Yes, ma'am.
we will today felicitate our chairperson of Foxy Vaginal Surgeries Committee, Dr. Suman Sinha ma'am. Madam is as beautiful a person as she is
In fact,
actually.
this may
She
be considered, but it is a very weak,
uh, Mit- ma'am,
recommendation.
Mitra
Support
ma'am,
team, please mute
Now, this
everybody.
is how
so what we can do is
now,
now.
more and more people, once you start thinking of conservative, you would like to give a transverse incision so that you can approach the low uterus.
Support team, please mute
Now, as far as
everybody.
the status of conservative surgery is concerned, there is very limited
Mitra
details
ma'am, I
on that.
have
But
to.
it is
Monica?
when the extent of placenta is limited in
Have you started the program?
surface
Yes,
area
we
that
started, madam. You have to
and
mute.
the entire
that,
placental inflammation is
If you want, I can just say because then I have to go my
Yes,
program. Has
madam.
Dr.
Please
Jaideep
do.
already
Yes.
spoken?
No, madam. Jaideep madam is yet to join. I'll be introducing you, madam. So
No, please keep this very small.
yes, ma'am. So we welcome amongst us Dr. Mitra Saxena, madam from Rewari, Haryana. Madam is the VP elect of North Zone Foxy, and she was the past chairperson of the Practical Obstetrics Committee of Foxy. She is a great teacher, a great surgeon, a great mentor, and she has taken everyone by storm by with the Tuesdays with Teachers program, which was very well appreciated, and she's still continuing in some form. Welcome, madam. We need your blessings, madam.
So, a very good evening to all my dearest friends who are here to join in this beautiful program, Synergy. I believe this is the 30th installment of Synergy, which has been conceptualized and executed by none other than a very dynamic obstetrician, Dr. Monica. And I have known her for a good number of years. And what I love about Dr. Monica is her spirit to bring the best of the teachers, speakers with their best of knowledge in these programs. It has been my privilege to actually even perform in her platform. And I must say, to bring 25 societies together and for a beautiful session on vaginal surgeries, I'm sure all those who are here are going to learn a lot. Please pardon me that I am not able to take individually everybody's name, but I must congratulate Monica, you and your team, all your dynamic Foxian friends, and I wish you the best of luck in all your future endeavors. May God bless you with wisdom and good health so that you can fulfill all your dreams. And now, please pardon me if I'm not here. I will be logged in, but not actively, here because I have a webinar. Bye bye, Monica. Best
Thank
of
you.
luck.
Thank you so much, Mitra ma'am. Mitra ma'am has joined as VP elect North Zone, and she is right now deliberating in an ICOG program on placenta accreta spectrum. Thank you so much for your time and kind words, madam. Jaideep madam has joined us. Our chief guest has joined us. Let us put our hands together to welcome our chief guest, Dr. Jaideep Malhotra ma'am. Madam is well known to all of us as the leader of leaders. Name the organization, and Madam is there. Uh, I first saw her leading Aspire many years back in Singapore, and afterwards, like there was no looking back. I've seen Niharika and Keshav grow up into dynamic doctors and really path-breaking professionals. Of course, Naren sir is there as a very big pillar of support, but Madam has got an identity of her own. She has led Aspire from the front. She is the past president of the largest organization of obstetricians and gynecologists of India. She is the past president of the largest association of ART practitioners in India. She is heading a big corporate hospital in Agra, the city of Taj Mahal ART Rainbow IVF. Many of my memories are associated with Agra. Many years back, madam, when you were not even in the family, my mother was a gynecologist in your nursing home in Agra when my father was posted there. And I used to visit the nursing home to see my mother. I was studying in St. Patrick's, Agra that time, madam. And when we went for the Foxy quiz to AICOG Kanpur, that time in Agra, we were invited and we stayed in Madam's nursing home because we did not have the money to afford a hotel or anything. So Naren sir said, Monica, you and your friend come to our hospital and you put up there. So madam, your memories with me are very sweet and fragrant. And 20 years back, 20, more than 20 years back, 25 years back, I asked, Madam, how do you become an IVF practitioner? So Madam said, Monica, the path is steep, it is tough, but it is not unachievable. Thank you for everything, Madam. I will not read your CV because we want to listen to you, ma'am.
Thank you so much, Monica, and a very, very good evening to all of you. Uh, in whatever I can see on this frame are highly respected people from our fraternity, whom I love from the bottom of my heart for all that they do for the women of our country. So, a big salute to each and every one of you. It's really, really heartening to see, all these youngsters today, Monica, after hearing you. I mean, I've known you for years, but the way you have actually developed and the way you are looking and the vision with which you're working is phenomenal. And that's exactly what we are expecting all our next generation to take forward. Uh, the program in itself, which called Synergy, and focusing on vaginal surgeries. Again, I feel, sometimes in this era of endoscopy, vaginal surgery is something which also needs equal mastery. You can't do everything with the scope only, and access from below is equally important, and that's where sometimes I feel now the training is lacking, like vaginal birth. This is another area which needs a lot of hard work for our next generation to be working on. So I really congratulate you for picking up this topic, and of course the speakers who are addressing are all stalwarts in this particular field, whether it's Dr. Hara Patnaik or Dr. Sarugi or each and every one of you. I mean, it's fantastic program which you have picked up, and I feel totally happy and satisfied when I see the program, because focusing on the areas which we really need to focus on is the timely intervention, which maybe I feel sometimes we are a little late, but it's still very timely intervention, which will take us a long way. So I really wish you all the best. I wish the program all the best. And I'm sure the deliberations are going to be very, very fruitful and insightful. Thank you for having me. Thank you, dear.
Thank you. Thank you, Jadeep ma'am. Thank you. And may you keep shining and guiding us in whatever little paths we take in life. And Niharika is also joined. She's a special guest for today. And before moving on, I would like to pay my respect to another Foxy dignitary who is with us, Dr. Suman Sinha ma'am. I was introducing ma'am because she, joined the program right in the beginning, and she is the person who is behind the conceptualization of this webinar. She's the one who suggested the topics and the speakers, and I just put them together. So she made my task very easy. Madam, you are propagating a technique which is not a dying art. It is actually a necessity everybody should learn. And trust me, madam, when we study, I have studied in medical colleges where obstetrics was given more importance than gynecology because of the sheer volume of obstetrics. So I had to learn all these surgeries way after post-graduation. So, madam, these techniques are so important, and any mentor or teacher who can teach you this remains with you for life. Madam, I welcome you for all your achievements, all your guidance, and you have a long way to go in Foxy, madam. We want to see you right shining in Foxy forever, and we would like to have blessings from you, madam.
Thank you, Monica. It's a great pleasure to be here, and thank you for inviting me. Can you hear me?
Yes, madam.
Yeah. So before I begin, Monica, I would like to wish you best wishes for your endeavors and for your election also. And yes, Monica, you're right. You have chosen such a good topic today, because all of the surgeries, needs 1 hole, 2 hole, 3 hole, but this is no hole surgery. And you don't need much of the training. You have to be consistent. You have to just see cases, assist in cases, and gradually you learn. And you don't have to pay much also. It is not very costly to learn. The instruments are also only 4 or 5 instruments are required. The basic instruments are required. And you can serve even in the remote places. We used to go in the remote villages and used to camp there and do vaginal hysterectomies whenever it is needed, because those women, for them it was very difficult to come to the bigger cities and get operated. So used to camp. So you can see these surgeries can even be done in camps. So it is a fantastic surgery. Thing is that you have to practice, you have to be consistent, and you have to learn. And today, whoever faculties has been chosen by you or by me, they are testament of academic excellence and surgical excellence. Dr. Saraogi sir, what to tell about him? He's such a kind person. I'm really obliged to him because I've crossed these 2 years of my journey because of him only. He has guided me at each and every step. Then comes Dr. Hara Patnaik sir, even Dr. Srikala, even Dr. Uma Rani Swain. So many of them are there, and they are very good surgeons. They are on the base. They never stand very high, but they are our teachers. I don't know what to say about them. They're next to God, I can say. So I think without wasting much of time, we can start the session soon. And as you have planned, go ahead.
Yes,
Thank you
ma'am.
very much.
Thank you so much, Suman ma'am. And we don't waste a single moment when we listen to you. In fact, we want to listen. It's as if we want to keep listening, but the program has to move on.
And I want to thank our chief guest, our president, Madam Dr. Jaideep Malhotra, Madam. She is also very inspiring because whenever she talks, she inspires the generation, I can say. So thank you, Madam, for being here and for blessing this webinar. Thank you.
Malhotra family has given a lot to the fraternity.
Yeah. To us also, Dr. Naren Malhotra was the first person to bring this committee to Foxy, which is his brainchild. So, Madam, kindly convey this to him.
Yes, Madam. So now I come to felicitate our guests of honor for this evening. Today we have amongst us our guests of honor. Dr. Gitendra Sharma is yet to join, but Dr. Yashodhara Madam is there, past VP of Foxy. A person who, she picks up my phone, she talks to me very sweetly. She said, Monica, you have not put a very good picture of me. I said, no, madam, I like this picture because you're smiling like your smile is reaching from end to end. So I love this picture, ma'am. So, madam, we have heard such a lot about you, and we want to have you as a speaker very soon in Synergy. You have lit up Lucknow with your knowledge and with so much of teaching experience, your blessings in every possible society of India, and worked very hard in Foxy. I know you have a passion for urogynecology as well as vaginal surgeries. You are the teacher of teachers. Madam, it's an honor that you are in the program, and we would love to have blessings from you, madam.
Thank you so much, Monica, and I'm so proud of you. I must congratulate you, in fact, that you are the one who is doing, you are the one who are going to, I really feel that how you people do so much work, that the 11 societies from Punjab and 14 societies from Haryana, you have how much you have to do the communication with everybody. That means all president secretaries of this 25 societies is a really excellent job. So I know you are the one who really a deserving person for your post of chairperson in fertility committee, and my best wishes to you. Your effort of your and Dr. Randhir and your team is excellent, I will say. And I am honored to be invited by you in the Synergy as a guest of honor. To thank you for giving me this opportunity. And this is the platform where we can meet so many people, especially the most inspiring person, Dr. Jaideep Malhotra. Nobody, everybody's known in the India and abroad probably also. that this is a wonderful couple, Dr. Naveen Mehrotra and Dr. Jaideep Mehrotra, and ready to help each and everyone. And similar is happening to, I am so good to see Dr. Niharika is also coming up, and she's also has completed her chairmanship, and now I am sure that she is going to higher positions. So my best wishes to her also. So I cannot take the name of all the president and secretaries, but I can say that I'm the one who organized my vice president conference in Ambala. So I know many people. In fact, I will say that when I organized this, people did not had so much idea about the Foxy. So these people, when this vice president conference was organized by Ambala Society, Dr. Poonam was there as a president. Everybody has appreciated because they all got a chance to be associated with the Foxy. And the Foxy people, on the other hand, was also very happy, the General Secretary, Dr. Madhuri, and President Dr. Rishikesh Pai, because uh, of course, Punjab is a north zone. But anyhow, they are themselves, they are so much competent that they probably do not need anybody. But they were very happy when they came to know that this vice president conference is going to be organized there. So the 11 society, the president and secretaries of the Punjab societies, Amritsar, Bhatinda, Faridkot, Firozpur, Jalandhar, Kotakpura, Ludhiana, Nabha, Chandigarh, Patiala, and Pathankot is there. And Dr. Shushma Chawla, who is a star, such a dynamic person. We have met long, long ago. We are good friends. We keep meeting now. I am also going less. I do not know about Shushma, whether she is also moving a lot or not. But
I'm doing it.
yeah, we
Yes.
have traveled so much that now it is the time to, we are just trying to give time to ourselves also. After completing our busy student, of course, I know you people are more busy doing their your things, but we have got different kind of the obligation as a teacher to teach undergraduate. Not only the subject, is the discipline, is the communication, so many things you have to teach. You are so busy, and now it is a changing world. India is changing in a such a pace that it is very difficult to keep. In fact, I admire my younger colleagues who are doing so a lot. And best speakers are there. You have chosen Monica. There's no doubt about it. Dr. Sarogi and Dr. Hara Patnaik. We have learned from Dr. Hara Patnaik is a very good friend of us. And Dr. Shrikala and Dr. Umaram, they all are wonderful speakers. So coming to the Haryana societies, Ambala, Bhiwani, Faridabad, Gurgaon, Hisar, Karnal, Rewari, Rohtak, Panchkula, Panipat, Parval, Sonipat, Sirsa, and Yamunanagar. That Haryana is such a small, but it has got a 14 societies. So my congratulations to all the present secretaries of the Haryana and Punjab for coming and joining this. So thank you so much. And Suman, you are doing so good, because I may not be able to log in all the time to the vaginal surgeries, but vaginal surgery is my passion, because I have been taught by very important, very eminent teachers, Dr. Engineer. We have seen Dr. Engineer doing the vaginal surgeries, and you should have seen that she used to dissect the flaps like she's peeling the onion. So we have been trained by such eminent teachers, Dr. AD Engineer. She was from probably from Mumbai only. She was from Mumbai, but she worked in our Lucknow, Queen Mary's department, as head of the department for 17, 18 years. And she was a wonderful person. She was Foxy president also. So her picture is also, whenever I used to go to the Mumbai office, I always check that her photograph is there.
This time I will check. I will go and see her.
Dr. AD Engineer. You see, Parsi woman is a big brooch and the Siddha Palla and all this. Very eminent person. If you have once met her, you can never forget her. So we have been taught by those teachers. So we think that we are also teaching our colleagues the same. And my teachers, my student, those who have become professor, they also admire when they have learned the vaginal surgeries from us. So thank you very much, Monica, for giving me the opportunity, and my best wishes to you, and my regards to all the president, secretaries, speakers joining this. And I'm there to listen to some time. May not be there till full time, but definitely I will be there. Thank you.
Thank you. Thank you so much for your blessings, Yashodhara ma'am. It was really nice to take us through Foxy and so many years. We relived your years through your words. And now I have the very, very pleasant duty of inviting amongst us the real star of Punjab. So I met Sushma ma'am when Niharika and invited me to Funference conference in Amritsar. So I was outside this hall in a beautiful hotel, and I saw a very regal royal lady in a red gown and a red rose walking inside the hall. And she said, I'm going to dance and I'm going to take part in that event. And I said, ma'am, I'm Dr. Monica Singh. And she said, okay, okay, okay. But she was so royal that we thought, how should I talk to her? But over the years, I became friends with Sushma ma'am. She is really the queen of Jalandhar. And we can see the long list of achievements in her CV, not only in Foxy, in IMA, in Doctor's Wing, in Rotary Club, so many awards, and everybody in Foxy knows her. So, Sushma ma'am, this stage is yours for you to speak to us, madam.
Yes, first of all, Dr. Monica Jindal, it's so sweet of you to have invited me. इतने प्यार से आपने बुलाया कि मैं कुछ ना कर ही नहीं सकी. And I wish you all the best. You are such a great person, and you got also so much of interest in, arranging so many webinars. And today's topic of vaginal surgery redefined. मेरे को याद है when I was in PGI 1967 to 71, Dr. P.K. Devi, they were such great teachers. The artificial reconstruction of vagina, हम लोग दिन रात बैठे रहते थे उनकी देखने के लिए कि ब्लैडर वो अपना कैथीटर ब्लॉक तो नहीं हो गया, हमारा ये विजाइनल ये डिजनरेट तो नहीं हो जाएगा. So vaginal reconstruction, then of course vaginal suspension, pelvic organ prolapses, anterior corporaphy, posterior corporaphy, urethral slings and whatnot, and now the vaginal surgery, labioplasty and clitoral hood reduction. No, the cosmetic surgery has come. So I think there is no end to it in vaginal surgery. And mine was the time we used to do everything. But now it is super specialty. And Dr. Hara, I know, wonderful person who is demonstrating all over India. I wish you all the best. You got so much to talk. So I wish you all the best. And lovely. Thanks you very much for inviting me and for your kind words. Thanks a lot. Good luck for your elections.
Thank you so much, Sushma ma'am. And your presence really means a lot to all of us. You are representing the whole state of Punjab.
Yeah, thank you so much.
Thank you, madam. And now our sweetest guest for today's evening is the past chairperson of the Young Talent Promotion Committee of Foxy, as well as the youngest stalwart of, I think Keshav is younger than Niharika. So she is the young stalwart who's the torchbearer of Malhotra family, with a terrific gynecologist, a beautiful person, very soft-hearted girl, lovely children she has. It's always lovely to talk to her and communicate with her. She has a lot of knowledge, insight into things other than gynecology, and that what interests me in a person more than subject knowledge. How much you are imbibing of the environment around you, because that actually makes you a complete person. And Niharika is a complete person. Welcome, Niharika, to the program.
Thank you so much, madam. And before I say anything, I really want to thank you. अभी तक मैं सारे webinars में anchor होती थी, master of ceremony होती थी. This is my first webinar which I am invited as a special guest, and I think this will go in my CV as one of the most memorable webinars I am here. It's such a pleasure to see all my seniors who are here, who have blessed me, pushed me always to do better. And I know that this topic today, which you have chosen, is amazing. And I think I have to congratulate the whole Synergy Club for keeping the discussion alive on invaluable surgical knowledge. And it is so important that today, in the era of robotics, artificial intelligence, we are still back to the root, learning from our masters and exchanging the practical knowledge which is there. And I'm sure all of those who are here with us connected will have a very enriching session. So thank you, Monica ma'am. Hello to Sushma ma'am, Yashodhara ma'am, and everyone. And pranam to all the seniors here. Truly, truly thankful. Thank you, ma'am.
Thank you. Thank you so much, Niharika. And it is youngsters like you who keep the spark burning, glowing in Foxy. So thank you for your words and thank you for your bright presence. And now I would like to thank my co-convener, my anchor, Dr. Randhir Singh. He is the backbone of the family, and so because of this, I can ignore so much of the family and do my programs. So thank you, Dr. Randhir. And now I would like to felicitate our societies from Amritsar. Amritsar, the city of Golden Temple, we have President Dr. Amrit Pal Kaur Dhillon ma'am, and we have Secretary Dr. Sangeeta Pava, a very dear friend. Next, we have Bhatinda, which is recently has got AIMS also, headed by President Dr. Monica Kapila and Secretary Dr. Ritu Goyal. Welcome to you. Faridkot, headed by President Dr. Jatinder Kaur and Secretary Dr. Jagjit Singh sir. Welcome to you. Firozpur, the place I was born. Dr. Dinesh Pathak, I just talked to him in the morning, is the president. Welcome, Dinesh sir. Secretary is Dr. Sarabjit Kaur. Next, we have Jalandhar, where I did my schooling. Dr. Seema Pasricha is President Jalandhar OBGY Society. And Jasmine Kaur Dahiya is the dynamic secretary. Next, we have Kot Kapura Faridkot, headed by President Nishi Garg Madam. Madam is there with us. She is a dynamic director of Garg Multispeciality Hospital with more than 3 decades of experience in gynae and ops. Welcome, Madam. Her secretary is Dr. Madhu Goyal. Next, we have Ludhiana, the city of industries, headed by, and I think this is the city famous for the number of Mercedes cars which were bought at one time. I remember this news in Ludhiana. So Manu Singla Madam is the dynamic president of Ludhiana OBGY Society, and my very dear friend Dr. Kavita M. Bhatti. She is the secretary of Ludhiana OBGY Society. Welcome to you, both of you. Nabha Society, headed by President Dr. Parneet Kaur and Secretary Dr. Preet Kamal Sibia. Next, we have Chandigarh Society, called the North India OBGY Society, headed by President Dr. Rashmi Bagga and Secretary Dr. Minakshi Rohila. And Patiala is the society headed by Sarita Agarwal Madam as President, and Secretary Dr. Ranjana Gupta, famous for its Fulkaris. And next we have Pathankot, headed by Dr. Beena Mishra. For those of us who don't know, Dr. Beena Mishra is the real sister of Dr. Professor Meera Agnihotri Madam, and her secretary is Dr. Prerna Sehgal Ma'am. Next, we have the Haryana OBGY societies, which are 14 in number. Ambala, headed by Dr. Ruby Bhatia Madam. Madam was busy today with her academic activities, so could not join, but I have talked to her. Dr. Aditya Garg, secretary, is with us in the program. Welcome. Bhiwani, headed by President Dr. Neelam Bisham Ma'am as president, and secretary Dr. Harsha Shekhawat. And Dr. Harsha has done post-graduation with my coordinator, Dr. Virul. So welcome, Dr. Harsha. Next, we have Faridabad Society, headed by a very respected Dr. Kiran Chandna Ma'am and Secretary Dr. Chanchal Gupta. Next, we have Gurgaon, the very dynamic society, the neighbor of Delhi. In fact, even more famous than Delhi nowadays. Saroj Kumar Madam is the president. Welcome, Madam. And Dr. Neeru Thakral is the secretary, who is also very, very active in IFS. Hisar Society is headed by ex-AMC man, Dr. Gurneesh Singh sir, who is the president, and his, all his defense knowledge will shines through when you talk to him. His secretary is Dr. Kritika Singh. Next, we have Karnal, headed by President Dr. Parul Behel ma'am. And Secretary Dr. Manisha Singhal. Dr. Manisha is there with us. Next, we have Rewari from where Mitra Saxena Madam belongs. Dr. Archana Yadav is the President of Rewari. And Secretary is Dr. Neeraj Yadav. Welcome to both of you. Rohtak, headed by Dr. Pushpa Daya, President, and Secretary Dr. Krishna Daya. And Panchkula, headed by President Dr. Renu Chakravarti Madam, Secretary Dr. Bhavna Agarwal. And Panipat is the new society which has been just added in Foxy. Dr. Shubhanjali Sen met me recently in Indore. She's the dynamic young president of Panipat OBGY Society, a great robotic surgeon. And her secretary is Dr. Pritika Nijara. Next, we have Palwal Society, headed by Dr. Suman Saraut Madam as president, and secretary is my batchmate, Dr. Sangeeta Gupta. We did MBBS together in Bhopal. Sonipat, headed by Dr. Shikha Kadia Malik Madam, and secretary Dr. Anjali Jain. Welcome to you. And Sirsa Society, headed by President Dr. Gargi Munjal, and secretary Dr. Snigdha Khurana. Welcome to both of you. Yamuna Nagar, Dr. Minakshi Sharma is the president, and secretary is Dr. Natasha Agarwal. So that brings us to the end of the welcome to all the societies who have given us their valuable collaboration. My program coordinators have got in touch with all of you. Dr. Juhi Agarwal is Professor Unit Head at GMC Bhopal. Thank you, Juhi. She has a great passion for vaginal surgeries. Thank you for being there. Dr. Purva Bhatkur is the one who has communicated with all of you for your CVs and your participation. She is the dynamic associate professor in GMC Bhopal. And we have Viral Srivastav, who is a very talented IVF specialist in the city of Bhopal. So welcome to all of you. And thank you for all you have done. And that brings us to the formal introductions are over. And we will start the first session. Over to you, Dr. Purva.
Thank you so much, ma'am. So, moving to our first academic session, that is on McCall's Skuldoplasty. We invite Chairperson Dr. Amrita Pal Kaur Dhillon, Madam. Madam is presently President of Amritsar OBGY Society. Dr. Anjali Jain, Madam. Madam is presently Secretary Sonipat OBGY Society. We have with us Dr. Archana Yadav, Madam. Madam is presently President of Rewari OBGY Society. We have with us Dr. Dinesh Pathak, sir. Sir is presently President Firozpur OBGY Society. We have with us Dr. Jitendra Kaur, Madam. Madam is presently President Faridkot OBGY Society. We have with us Dr. Juhi Agarwal, Madam. Madam is presently Professor and Unit Head in the Department of OBGY, GMC Bhopal. We have with us Dr. Kavita M. Bhatti, Madam. Madam is presently Secretary of Ludhiana OBGY Society. We have with us Dr. Kiran Chandana, Madam. Madam is presently President of Faridabad OBGY Society. We have with us Dr. Manu Singla, Madam. Madam is presently President of Ludhiana OBGY Society. We have with us Dr. Ranjana Gupta, Madam. Madam is presently Secretary of Patiala OBGY Society. We have with us Dr. Renu Chakravarti, Madam. Madam is presently President of Panchkula OBGY Society. Now I hand over the session to our chairpersons to introduce our speaker, Dr. T. Srikala Prasad, Madam, for her keynote.
Dr. Dinesh Pathak, sir, are you there? Dr. Dinesh, sir, are you there?
Yes, I am here.
Sir, please, could you do the honors by introducing our first speaker, sir?
Yes, sure.
Thank you, sir.
Yeah, a very good evening. Today, the first topic is on the Macal Skuldoplasty. Dr. T. Shikla Madam will be talking on it. She is retired professor in HOD, Urology, Government Kilpuk Medical College, and Senior Consultant Prime Indian Hospital. She has a lot of achievement in her name, like she is Honorary Joint Treasurer and past Secretary of OGSSI and Vice President of South Zone of Vaginal Surgery Society, Vaginal Surgery Society of India, and she has written chapters in Urogyne simplified by JP Brothers and Autologous Rectus Facial Sling and Vaginal Apical Suspension Procedures. She has written multiple chapters in Foxy Focus books and also chapters in urological injuries in obstetric practice in book on medical legal update in obstetric gynae.
Thank you, sir.
Over to you, ma'am, for your.
Yes, sir. Thank you, sir. Thank you,
David.
sir, for the nice words of introduction. Respected Sarogi, sir, and a whole lot of seniors. I won't be able to name them individually, but I'm simply amazed at the number of seniors here. So, my pranams to all the seniors and my dear friends. We will go on to the topic. Let me share my PPT. Okay. So today I'm going to talk on mechalcaldoplasty. Why this topic? Pelvic organ prolapse is a common bread and butter surgery. 30% of the patients worldwide require surgery for recurrences. So not only we are worried about the primary surgery, we are worried about preventing any recurrences. So mechalcaldoplasty is a simple form of apical suspension, not only for vaginal hysterectomy, normal prolapse, but also for doing NDVH, LAVH, and TLH. See, the major cause of recurrence itself is failure to do an apical suspension, which is very, very important. So what are the vaginal apical suspension procedures? You have the most simplest form as mechalcaldoplasty. You have high uterosacral ligament suspension, sacrospinous ligament suspension, iliococcygeus suspension, and the transvaginal mesh placement to augment apical suspension is now a matter of great debate. And because of the US FDA ban, we are no longer doing that except for legends like P.P. Piley sir, who is doing a great job about it. Similarly, these apical suspension can be done by abdominal, laparoscopic or robotic procedures by doing a sacrocolpopexy and a uterosacral ligament colposuspension. So, what we should do? I listed so many procedures, but we should know what we are going to do. So, what we need to remember is in simple, say, non-descent or lap hysterectomy or 1, 2, even up to 3, it is enough if you do a mechalcaldoplasty. But if you are dealing with a mass like a prostodentia or a stage 4 pelvic organ prolapse, we need to do a robust apical suspension like a sacrospinous or a high uterosacral ligament suspension. These are the RCOG guidelines. So what does the RCOG guidelines tell us? It tells that what are the methods which can be used at the time of hysterectomy to prevent vault prolapse. As I was saying, mechalcaldoplasty at the time of vaginal hysterectomy is effective in preventing a subsequent post-hysterectomy vault prolapse. And what are you going to do in abdominal? If you suture the cardinal and the uterosacral ligaments to the vaginal cuff at the time of hysterectomy, it is effective in preventing post-hysterectomy vault prolapse. This can be done either we are doing it from below or above. For the benefit of the juniors, we should know when mechal is enough or when you need to do robust surgeries. Initially, I was telling if it is prostodentia, you need to do a robust procedure. Another simpler way is after you have done a hysterectomy and you have closed the vault, if the vault descends to the introitus during closure, that time you have to do a more robust procedure like sacrospinous. Otherwise, mechalcaldoplasty itself is enough. So what is mechalcaldoplasty? The main principle of mechalcaldoplasty is plication of the uterosacral ligaments. You want to anchor the uterosacral ligaments to the vault. So this provides apical support and also cures or prevent enterocele formation following a hysterectomy. So the mechal or posterior caldoplasty, 1 minute. Okay, was originally described in 1957 as an apical support procedure and as an enteroceal repair procedure. And now we consider it as an adjunct to vaginal hysterectomy that might prevent a prolapse. So there are two types, that is an internal MECAL and an external MECAL. In internal MECAL, always you remember we are going to use non-absorbable. Whereas when you're doing an external, you can use a absorbable or a delayed absorbable. So following vaginal hysterectomy, the enteroceal sac is obliterated using a series of non-absorbable sutures which pass through each uterosacral ligament and include the intervening cul-de-sac peritoneum. So sequential sutures are placed proximally until the entire enteroceal is closed. MECAL actually recommended at least using 3 internal non-absorbable sutures. However, we can decide on the total number depending on the size of the enteroceal. So you take the stitch and you keep it till finally. So this is the picture. See, you can see these are the internal sutures. So you start from the vagina, go to the uterosacral, take the bite on the peritoneum and come out. So from below, you can go up, you can even take up to 3 steps. That is internal. External is you take from the vagina and then you go to the uterosacral, come on this side and again come. Whenever you're doing an external MECAL sutures, you must use only delayed absorbable. So in external, absorbable sutures are passed through the posterior vaginal epithelium through each uterosacral ligament and then through the posterior vaginal epithelium on the contralateral side. Can you see? So you're taking it posterior vaginal wall, uterosacral and then come out. The most proximal suture is placed at the vaginal apex to ensure maximal length. The internal sutures are tied first, creating a shelf that suspends the vaginal apex once the external sutures are tied on. MECAL suggested that the vaginal length would be increased by not excising the enteroceal sac or the posterior vaginal epithelium. Almost all of us, we follow a modified MECAL cultoplasty. I will show you the video of that also. So what we have to remember is we have to anchor the uterosacral ligament to the vault. That is the most important thing. So I will show you this video. Here I am doing, can you see I am taking a bite on the posterior vaginal wall. Okay, on the uterosacral Meckenroth's complex. Can you see I've held after the posterior vaginal wall, I'm taking a bite on the uterosacral ligament. Now, can you see the posterior vaginal wall? I'm going above, taking a bite the apex as high as possible. And now here you can see this is the edge of the peritoneum. Actually, I've held the edge of the peritoneum and the posterior vaginal wall together. So you can put a approximating sutures. So the first suture you take on the posterior vaginal wall, then take on the uterosacral Meckenroth ligament complex, go inside, take the peritoneum and then come to the edge of the peritoneum and the vaginal wall and tie. That is the first step. Now, see, can you see? You can see the peritoneum easily. I'm going high above, taking a bite on the peritoneum and the apex. Now what we should do, we should catch the edge of the peritoneum. So edge of the peritoneum and the vaginal wall, I have held it. So I am taking a bite. So from here till we come to the end, we will take the apex of the peritoneum. Can you see? I hope you're able to see the peritoneum nicely. I'm going above as high as possible, taking the peritoneum. Here you can, below you can see the edge of the peritoneum as well the posterior vaginal wall. Now again, I'm taking the peritoneum. So this is the right uterosacral Meckenroth complex. Now you come to the edge of the peritoneum and the posterior vaginal wall and tie. Now, here you will be able to see that the vault is outside the vulval outlet. So this Meckel caldoplasty, I wanted to demonstrate so easily you see the peritoneum wells. So I've done this, but this will not be enough. So after you approximate the vaginal wall, do the cystocele correction and everything, you have to do a concomitant sacrospinous colpo suspension. So the procedure has high success rates and lower reoperation rates. Complications including urethral obstruction from kinking or injury in less than 3% of the cases. So you really don't even need to have a cystoscope. You can even put your hysteroscope and see for the efflux of dye. If urinary efflux from both the sides. Post-operative care follows similar to most vaginal surgery hospitalizations, varying from 1 to 3 days. Return of bladder and bowel function dictates, of course, and you delay after any vaginal surgery, we delay the intercourse and see the patient in the post-operative period to allow for inspection of the vaginal cuff healing. I just, many of my postgraduates wanted us to show how to go, open the peritoneum. That was another doubt which many people were asking. So I will just show another video. So you are after any pelvic surgery, you will catheterize. Here you are seeing where I am going to put the incision. Okay, and see, this is the meatus. This is the transverse vaginal sulcus. Here I am moving to.
Madam, we can't see the video.
Oh, 1 minute, madam. 1 minute. I'll just 1 minute. I will just cut it and then maybe now again I will. அந்த வீடியோ ஒரு காமிக்க சொன்னேன். வீடியோ இங்க வர மாட்டேங்குது. அவர் வர சொல்லிட்டாங்க. Just 1 minute.
Yes, ma'am.
I had checked and it was coming, but now I don't know. I'm just 1 minute.
It's okay, madam. We have got time.
Just.
In the meantime, if anybody has got questions, you can put them in the chat box. You want to send the video to our team, madam? Then we can play it.
It's a big GB, so it will not come. Just give me 2 more minutes time.
Sure, ma'am. Please take your time.
I'm actually stop share. I will do, and then I'll just try. Yes, and the video போட முடியுதான்னு பாருங்களேன். Madam, is it audible?
Madam, yes, ma'am. We can see the video.
Yes. கொஞ்சம் முன்னாடி போட்டுங்களேன். கொஞ்சம்
You can
முன்னாடி.
see the video.
Yeah. What I wanted to say is for the benefit of the postgraduates. So emptying the bladder and see with the same catheter, I'm trying to see where to put the incision. And similarly with the see, this is the meatus, the transverse vaginal sulcus. I'm moving the valsalum, similarly lifting the anterior vaginal wall. So you will know where to put the incision. So that is not any magic. It is just like mathematics. One, you put the metal catheter and see the extent of the bladder. Two, you do a little movement and then you'll be able to see. Three, you lift the bladder. Similarly, here also that loose fold. which will connect the peritoneum, no? That then you will open into the pouch of Douglas without struggling. So before you actually put an incision, you have to ensure you're putting it in the right way. Many postgraduates I see, they have difficulty in opening the A pouch and the P pouch. So if you follow these landmarks, can you see it is beautifully opening? So once you open the anterior and the posterior pouch, the surgery is half done. So again, now I'm holding the anterior lip, nicely lifting up. Can you see the bladder is, I'm lifting up. Now you can use your sharps, your scissors, and then cut the pubovesicocervical ligament, and then you can see, now I can even push with my finger. And then, so I wanted to show this opening the anterior and the posterior pouch for the benefit of the juniors, because madam was telling there are a lot of postgraduates here. So see, now this hysterectomy also maybe I can little advance. The clamps everybody will do. The first clamp on the uterosacral McInrod's ligament, then uterine, all that is easy. And then after we finish, now again, see, this is what I wanted to show. So you're doing completing the hysterectomy by putting the clamps. But nowadays, many of them are going for energy devices. So that is also good, but maybe I'm a little conservative. I use the suture still, but using energy devices is a good option. Now, see, can you see? You should push the bowel nicely. Take the posterior vaginal wall, bite on the posterior vaginal wall, and take a bite on the uterosacral ligament. Why am I showing another one again is, this is a simple procedure which can be done by all gynecologists. A retractor I have put so that no bowel comes. Can you see me taking it on the peritoneum? So first uterosacral and posterior vaginal wall, uterosacral and McInrod's, peritoneum as high as possible. Then I came to the edge of the peritoneum, vaginal wall and tie. Again, good retraction. I'm taking the peritoneum alone. This we can do with, I'm doing with Vicryl. You can even use with PDS also, but not non-absorbable. You must not use proline or ethylone. This is a very simple procedure, which is a very good form of apical suspension, but of course not for prosidentias. You can do it for all vaginal hysterectomy, abdominal hysterectomy, even non-descent and even lap hysterectomy. Either you approximate the uterosacral from above, or if you're doing a vaginal closure, you can do this. Can you see I'm taking a bite on the uterosacral complex, edge of the peritoneum. So it will obliterate the enterocoel, achieve good hemostasis, and prevents vault prolapse. So this is can you see here the vault is going inside. Okay. So in this patient, this itself will be enough. So these are the rest of the cystocele correction, etc. I mean, these are normal. So what I will stop share here. What I wanted the postgraduates to remember is Meckel caldoplasty is a very, very simple, just I will stop share 1 second. Stop share. So Meckel caldoplasty is a very simple procedure, can be used on a daily basis, where we can, the main aim is approximate the uterosacral pedicles to the vault, which is a simple procedure. That is the message I wanted to convey. It can be done on a regular basis, a very simple procedure.
Very beautiful,
hope-
beautiful videos, madam. Very clear. Every step we could see.
Thank you. If there are any questions, we can take up.
So this talk is open to discussion now. I can see so many chairpersons and participants. We have Dr. Juhi also there. We have got Mitra ma'am is still there, though she might be busy. Purva is there from GMC Bhopal. So you have any questions? Dinesh sir, Nishi madam?
I
Yes.
just wanted to ask.
Discuss just while we are performing this vaginal hysterectomy for the prolapse, if we are dissecting all the, taking out the uterus and doing the anterior and posterior colporrhaphy, while I have what I have learned that while performing this surgery, I used to take the angle uterosacral ligament, connect it with the ovarian with the posterior peritoneum, and again on the opposite side, and we tie it together. That also I have not found any prolapse post-operatively.
Yes. So the carry home message is approximate the uterosacral pedicles to the vault. That's very simple. And by the way, we have shown this modified Meckel caldoplasty is very good, provided it is not a procedentia. So how we see, some of my postgraduates will be saying, "Madam, I'm very worried whether it is procedentia is only 3." So that is why the RCOG tells you, after you have done everything, is a vault coming at or outside the introitus. If it is coming at or outside the introitus, this is not enough. You need a more robust procedure like a sacrospinous.
Yeah. Purva, you were asking something?
Ma'am, I was just asking, is there any difference between internal and external Meckel?
Yes, ma. Internal, we do with a non-absorbable. We don't come out of the vagina. You take from the uterosacral pedicle on the left side, go through the peritoneum and go to the uterosacral pedicle on the other side. Like that. So the first one from below you put, then you go above and put maybe 2 to 3, use non-absorbable. But when you do an external, you do from the vagina. You take the uterosacral pedicle, again come to the vagina on the opposite side. In a
And then
modified, you start from the left and go till the right. But when we do a modified Meckel caldoplasty, we do with a delayed absorbable, start from the vagina and the uterosacral ligament and go all the way. In internal, you will be doing layers of, serial rows of internal suturing. So many are a little worried about doing that. So this is a simple way by which you can obliterate the pouch of Douglas, prevent enterocele formation and give a good support.
Very nice.
Okay.
So I got to know, Dr. Shrikala, it's like a pelvic floor repair, which normally done for all the vaginal surgery.
No, madam. In normal pelvic floor repair, we concentrate on anterior colporrhaphy and a posterior colpoperineorrhaphy, a rectocele repair.
We don't touch the uterus.
Yeah, we don't touch the uterus.
Then no, pelvic floor repair, you have to do this thing. That is what I am saying in what Dr. Dinesh has said. We always take a bite from one side and then go to the peritoneum, then take the other side and tie
if you are doing like that, it is very well and good.
This is what we have done.
That is great, madam. But what
we all have been taught like this only.
Yes, madam. But what we see many people is they do the vaginal hysterectomy and then go for a anterior repair and a posterior colpoperineorrhaphy, and it ends with that. So that is why, and we see a lot of vault prolapse. The incidents are becoming more than the book incidents.
It has become very common because people are not taking care of the uterosacral ligament and tying together in the center. And
another one thing is, in India, we are having more number of people doing laparoscopic work. In laparoscopy, they are extremely good. They do a good job and do the hysterectomy. But when it comes to supporting the apex, that is missing. And many a times we see gen surgeons also doing the hysterectomy, and this apical suspension is not being done. But now there are a lot of improvement. They do take the whole purpose of today, Monica and everybody trying to put this. We need the apical suspension to be done
Yes.
for everybody,
It's
whether
one
you are
of the
doing it.
it's one of the most important part of the whole vaginal
Yes,
hysterectomy.
madam.
Yes.
Yes, yes. You have
Otherwise, you
nailed
get
it.
or the abdominal hysterectomy also.
Yes, madam.
Otherwise, because these days we are seeing more often a word prolapse than we
Yes,
used
madam.
to see long ago. In my
Yes,
student
yes.
days or in my early faculty days, we have not seen any, in fact. But
Yes.
then as I grew in my career, I started seeing all this, and it is not easy when it is a word prolapse.
Yes,
It
madam.
becomes a little difficult. If you do it with the surgery, it is very easy.
The textbook standards say, sir, Sarogi sir?
Yeah, if you look at enterocele, basically it's a sliding hernia.
Yes.
sir.
And sliding hernia is occurring between two uterosacral ligaments.
Yes.
So what we do is to prevent sliding hernia to occur is we approximate both the uterosacral ligament
Yeah, in the
like
center.
this. So there is no space for the sliding hernia to come out.
Yes.
If you can consider this way, it becomes much easier for you to understand that basically you have to approximate both the uterosacral ligament because that is the space from which the sliding hernia or enterocele descends.
Yeah. You have
Yes.
to do in the center.
And the current trend of doing more laparoscopic hysterectomy is a minimally invasive procedure, definitely encouraging everything. But even if you do a laparoscopic hysterectomy, please see that you approximate the uterosacral ligaments either from above or from below. That is the message we want to be conveyed.
Can be tied
Very
from
nice,
above.
very nice deliberation, Dr. Srikala.
Thank you, madam.
Very nice.
So the
Thank
message went home, Madam Srikala ma'am. I think
Yes.
everybody who wants to do a seemingly simple hysterectomy has a responsibility towards the patient so that she doesn't land up with a wall prolapse.
Yes, ma'am. Actually, even if it is a high uterosacral ligament suspension, we may be worried to do. But this is a simple procedure which can be done by all the gynecologists. And if you are worried that you are worried, you put all of you will, everyone is now having a hysteroscope. So you can put in a hysteroscope also and visualize if you are worried, at least for the initial few cases.
And what do you visualize with the hysteroscope? What did you mention?
I know, madam, because of the worry of any ureteric inclusion,
Okay, right.
just put in a scope and see the efflux.
Yes, definitely. So earlier when we did not have the hysteroscope, we used to call for the cystoscope and do our
Yes.
hysteroscopy. So
That
it's
may
very
not be
easy.
possible always.
Yes.
That unless you are in a center where you have your urology colleagues, you may not be possible. So this would be easy. And initially, if you're a beginner, you can even give 2 tablets of pyridium or 1 or 2 hours before. So that coloration of the urine, you will easily see the efflux. Otherwise, for you to locate the orifice, it may, at least for beginners, for people like Uma, it is jiffy, it will come easily. For other people, for them to, as they cross the urethra, bladder neck and go to the trigone and see, it will take a little time for the urine to come out. So, but if it is a colored urine, it is easy for us to pick up. So that is how we play safe. Though it is not needed in all cases, it is safer
Whenever
to do.
you are in doubt, you can do it.
Yes, ma'am.
Thank you. Thank you so much, Srikala ma'am. I think that brings us to the end of the first session. And thank you to the first speaker to really bring light to the subject and deliberate very lucidly and very nice videos, madam. So again, I repeat, this whole session, all the 4 talks are recorded on YouTube. So anybody who wants to watch the videos again or want to share, please feel free to take the link from us. We will be sharing the link in the group.
Share the link also, na?
Yes, madam. I'll share the link in the Synergy 30 group, the link to the YouTube channel. So, thank you, Srikala ma'am. Thank you so much for your presence. We are waiting to hear more good talks from you and watch more of your fascinating videos in the successive webinars. And that,
sure, it's a pleasure.
Thank you so much, ma'am. So that brings us to the end of session 1. I request Dr. Virul Srivastav to start the session 2.
Yes, ma'am. Streets. Good afternoon, everyone. Thank you, Shrikala ma'am, for the wonderful video, ma'am. It was so good to see videos after so long. Now we are proceeding toward the session 2, which is on the topic Lee-Ford colpoclisis. For that, we have panel of chairperson. First, we have Dr. Adit Garg, sir. He is a secretary at Ambala Society. We welcome you, sir. Next, we have Dr. Chanchal Gupta, ma'am. Ma'am is director and HOD at Yatharth Super Speciality Hospital, Faridabad. We welcome you, ma'am. Next, we have Dr. Gurneesh Singh, sir. Sir is president at Hisar Organic Society. We welcome you, sir. Next, we have Dr. Jagjit Singh, sir, secretary at Faridkot Organic Society. We welcome you, sir. Next, we have Dr. Krishna Dahiya, ma'am. She is secretary at Rohtak Organic Society. We welcome you, ma'am. Next, we have Dr. Kritika Singh, ma'am. Ma'am is secretary at Hisar Organic Society. We welcome you, ma'am. Next, we have Dr. Monica Kapila, ma'am. Ma'am is president at Bhatinda Organic Society. We welcome you, ma'am. Next, we have Dr. Neelam Bisham, ma'am. Ma'am is president at Bhiwani Organic Society. We welcome you, ma'am. Next, we have Dr. Neeru Takral, ma'am. Ma'am is secretary at Gurgaon Organic Society. We welcome you, ma'am. Next, we have Dr. Prerna Singh Sehgal, ma'am. Ma'am is at Kalyani Hospital, Pathankot. We welcome you, ma'am. Lastly, we have Dr. Suman Saraut, ma'am. Ma'am is president at Palwal Organic Society. We welcome you, ma'am. Now, I request our chairperson to introduce our speaker for this session, Dr. Rajan Saraogi, sir. Thank you. Dr. Monica, ma'am.
Yeah. So I take the extreme pleasure in welcoming our illustrious speaker and teacher of teachers, Dr. Rajendra M. Saraogi, sir. I had the good opportunity and privilege to interact with sir many times in the past week or so, and every time sir has received my call and been very gracious and always ready to share his knowledge with us. We know that sir is Professor Emeritus at the renowned Seth GS Medical College and KEM Hospital, Mumbai. Sir is retired HOD at the Dr. R.N. Cooper Hospital, Mumbai, Senior Consultant, Nanavati Super Speciality Hospital, Director of the Saraogi Group of Hospitals, and founder member and trustee of the Association of Fellow Gynecologists, Mumbai. Sir, you are welcome to start your deliberation.
Good evening, everybody.
Dr. Purva, can you start sharing?
Good evening, sir.
You can have the first slide, Purva.
Yes.
Good evening, everybody. I am Dr. Saraogi from Mumbai. I am going to talk about Lee-Ford colpoclisis. If you look at the word Lee-Ford, it's a medical context. Kolpo is a prefix derived from Greek word of kolpos, meaning hollow, fold, or womb, and it refers to vagina. Clisis is a medical term meaning surgical closure or obliteration of an opening, often used as a suffix in medical words. For example, colpoclisis is a surgical procedure to close the vaginal canal. And that is what I am going to show. Next, please. Next slide, please. A colpoclisis vaginal closure is a surgical treatment option for pelvic organ prolapse in which length of the vaginal canal is shortened. It is performed through the vagina and does not require any abdominal incision. Mind you, this is one of the most important things as far as Lee-Ford's colpoclisis is concerned. Next, please. What's the principle of surgery? Principle is to close the vagina partially or completely with the prolapse reduced above. 3. These surgeries are generally carried out in very old post-op menopausal high-risk patients where anesthesia is contraindicated. It should be done in patients who does not desire sexual function, and there should not be any uterine or pelvic pathology. Next, please. Hence, the indication becomes old postmenopausal woman patient with third-degree uterine prolapse with healthy cervix. Mind you, healthy word is very important. She is not interested in further childbearing or sexual function. She is medically unfit for surgery. That means anesthesia can't be given. and it can even be used successfully in a case of wall prolapse. Next, please. Next. What are the contraindications? Patient with intact uterus who is not menopausal. If she is not menopausal, please don't think of using this surgery. If it's a bad cervix, she has uterine pathology, again you can't perform this surgery. And if she is interested in further sexual intercourse, this surgery is definitely contraindicated in these patients. Next, please. We cannot have a cafeteria approach in prolapse surgeries. And that is why, if you realize, we have so many surgeries available as far as vaginal approach is concerned. We have Schrodker's uterosacral advancement, we have Fothergill's repair, we have anterior colporrhaphy, we have posterior colpopeniorrhaphy, we have Nadkarni sleeve operation, we have vaginal hysterectomies, we have Lefort surgery. All sorts of surgeries are available. The operative technique should be combined with appropriate clinical examination to obtain maximum benefit to the patient. That means every patient you have to be very particular what surgery you would like to do on the patient after discussing the case with the patient. Next, please. What is the procedure? Procedure is simple. Denudation of rectangular vaginal flaps from anterior and posterior vaginal walls. Apposition of the denuded anterior and posterior vaginal walls. The reduction progresses step by step with blessing of the sutures and when two surfaces are united throughout the reduction of complete walls. This you will see in my subsequent video. You will find that ancillary surgery can be performed along with this, such as perineorrhaphy, which can give good support to the perineum. SUI surgery in the form of Kelly stitch mesh plasty, which is being devised by me. TVT, TOT can also be performed along with this surgery. Next, please. Advantages: can be performed under local anesthesia or Xylocard. Why I've used the word Xylocard is because in a case of heart problem, you can use Xylocard instead of using Xylocaine. It is very simple, that you will see subsequently, can be performed rapidly, gives good satisfactory results, can be performed in a case of third degree uterine descent with cystocele rectocele, and it can be performed in cases of precedentia as well as in cases of wall prolapse. Next, please. Success rate is almost 95% and post-operative pain is practically nil. Practically nil. I am using the word practically nil. Next, please. As I mentioned earlier, contraindication is patient with intact uterus who is not menopausal, bad cervix, and patient requiring sexual function. Next, please. What are the disadvantages? It can result in SUI. People have seen 30% increase in chances of getting SUI. There can be hematoma formation if you are in a great hurry to perform the surgery. Next, please. In nutshell, if you go through algorithm, A, it should be performed after menopause. B, blood loss is practically negligible. C, it can be performed in cases of comorbidity like heart disease, hypertension, unfit for anesthesia. D, damage to adjacent organ is practically negligible. E, economic. F stands for fast recovery, no failure. Next, please. G, the operation is very good. Hospitalization is for 1 to 2 days. Instruments are practically nil. Whatever I had used, purchased about 45, 46 years back, I am still using the same instruments. J stands for Juna technique but forgotten by everyone. K, knowledge first poster can do it. L, low morbidity, local anesthesia is being used. Next, please. Mortality is practically nil. It has to be done in menopausal patient. No pain. Obese patient, old age. Postmenopausal, practically painless. Quick recovery. Recurrence chances are practically nil. Next, please. No scar, sexual function not possible. SUI can occur, simple, underutilized. Time used is hardly about 20 minutes. You will find out in my next video. Understanding is very easy, it's very effective, and working gives more satisfactory. Wound infection is much, much less. Next, please. We have another surgery which is called as Goodall-Powers modification of Lefort's operation, which was performed for the first time in 1937. It can be performed in patients with intact non-pathological uterus, where a triangular area of vagina is marked about 2 cm above the cervix. The apex of triangle covers about 1/3 of the vaginal length. Sufficient lateral space is left for drainage of cervical secretions. The vaginal area is denuded of mucosa. The same step is repeated on the posterior wall. Mucosal edges of triangular base are approximated with 1/0 Weichel. That means practically it is same as Lefort's, except for the area which is covered is about a triangular way, and 1/3 of the vaginal length is covered. Next, please. What are the advantages of Goodall-Power? Its vaginal function remains satisfactory. 1/3 length of vagina is preserved. Sexual function is maintained. The disadvantages are cystocele and rectocele repair requires separate surgery. Next, please. We have Dani stitched by our own Indian. Dr. Suhas Dani from Government Medical College first performed this operation, which was published in Jogi in 1989. Also called as introital tightening, similar to Thursh's stitch of rectal prolapse using Sutu pack. I don't know how many of you are aware of Thursh's stitch in a case of rectal prolapse. It's a very simple surgery. It's something like making introitus very tight. That's all. Next, please. The advantages are less tissue trauma, decreased bleeding, no SUI, pap smear can be taken, and free drainage of vaginal secretion can occur. Next, please. Thank you. I'll show you my video. This video I had performed in cases of AFG. We have Association of Fellow Gynecology. I have performed 18 live surgical workshops in AFG. I have performed 6 live surgical workshops in AICOG. And this video was taken during one of my surgical workshop by AFG. We can have the video, please. Now this video is there already on YouTube. Make it full and let the voice also come, please. Let the voice come. There is no voice.
Purva, what about the audio?
Yes, ma'am, I'm sharing.
You can restart with the audio.
And once you'll see this surgery, you'll realize how simple the surgery is. Can be performed easily under local anesthesia. I had performed this surgery in one of our live surgical workshops under local anesthesia. And people were shocked to see this surgery being so simple. And 95% success rate.
Sir, your ABC algorithm was very nice.
Thank you.
Enjoyable.
Is the voice?
Yeah. Lafort's colpoclysis or Lafort's repair is generally being done for third degree uterine descent with healthy cervix in a postmenopausal woman who doesn't have any uterine pathology. After taking the labial stitches, we demarcate the incision line on the anterior surface. Similarly, demarcation is being done on the posterior surface. Either you can use a marker pen or you can use methylene blue. After demarcation, if there are no contraindication to use saline adrenaline, one can use saline adrenaline diluted, 1 in 2 lakhs, or only saline can be used to demarcate the planes. You can inject anywhere between 80 to 100 ml of normal saline. After doing that, the incision is taken first on the posterior aspect. What happened? Continue.
Dr. Purva, I think her network has gone, sir. She will restart.
Okay, no problem.
Purva?
You can use even xylocaine adrenaline. Because then xylocaine will give good local anesthesia effect. And adrenaline will help in preventing blood loss by causing vasoconstriction.
I'll just call her, sir.
Yeah, no problem.
Dr. Sarogi?
Yeah, hi.
Yes, sir. Thank you. Just to patch this time, actually, I just
Yeah.
want that you have told us that it's a medically unfit patient. Do not do in a medically fit patient.
No, we can do it in a medically fit patient also, but in medically fit patient, you will not think of doing Lifort. You will straightway go ahead with hysterectomy, no?
Even if you know that she is not requiring a family or she is not sexually active, you do not do Lifort. This is such
You
a simple
can
procedure.
do, see, you can do because it doesn't require anything more, just a local anesthesia, and you can go ahead with it. But basically, why I thought of talking about medically unfit is because it becomes much, much easier, no?
Yes.
That's the
And
main
second,
reason.
sir, if there is a big
Medically fit, why they will go for this now? Because there is chances of SUI now, 30%
Yeah.
success.
But actually, there is no SUI. Practically speaking, SUI only stay
So I
for
have said,
1 month to maximum 3 months. I do colpoclysis left and right. But this SUI and all, the occurrence is around less than 25-30% of the people. If I have done 50 cases, then this SUI self-dissolve. It doesn't stay for long time. Because this is a modification of Lipot, we just exclude the urethra and the bladder neck.
Is about to come. If you go about 4 centimeter below the external urethral meatus and make an incision,
Yes.
you are excluding the urethra altogether. There is no question of SUI developing.
Exactly.
I
Exactly.
totally agree on that point.
Sir, just make me a clear this thing that if there is a patient has a big cystocele,
Yeah,
okay, and you are planning for a colpoclysis,
correct.
that can that cystocele, big cystocele can be reduced and it will stay for longer time?
Your
Yeah,
repair or
because I'll tell you, Uma, even if it's a first and foremost, let me tell you one thing: if there's no cystocele, the operation becomes much more difficult. With a cystocele, it becomes much easier because the fascia over top of the cystocele, you keep taking bites from the fascia over the top of cystocele and approximate it posteriorly with the rectal fascia and keep approximating it. If there is no cystocele, it's going to be little difficult.
yes.
And with cystocele, what happens? That fascia also becomes thick, no? It becomes much easier.
Purva, can you start now? Hello?
Yes, ma'am. Ma'am, it just got stuck. Yes.
Doesn't matter. Go to that point where we ended. Little bit of overlap is okay.
After cutting the posterior vaginal flap, now we excise the anterior flap. Anteriorly, you have to be little careful because bladder as well as the urethra comes over there. If you look at it, you will realize that on both the sides, I have kept little vaginal flaps which acts as a tunnel. In case any discharges occur later on, it can come out through these tunnels, which you will see in subsequent surgery. A gradual dissection of the anterior flap is being done, gradually separated from the bladder as well as the urethra. If you have injected properly in proper planes, you will find literally you can peel it off. See here, you can see the anterior flap is being peeled off. Once that is being done, you will realize that you have anteriorly raw area as well as posteriorly raw area with vaginal mucosa on both the sides. Now gradually we will take stitches, maybe 3 or 4, and convert this into a tunnel. We don't tie the stitches, we hold it initially. When you take lateral stitches, you see to it that you form a tunnel laterally. Now we pass either a rubber catheter or you can pass a polyethylene catheter. This is just to maintain the patency so that later on, once the catheter is being removed, you will find that which come out from the cervix will come out of these tunnels. Now we tie up these sutures which we have taken and we hold them properly. These sutures act as support. See here, you can see the movement of the catheter nicely. Now we are taking sutures through the fascia over the bladder as well as on the posterior vaginal raw area, gradually covering the areas. Now whenever you take stitches on these raw areas, you try to take it in a zigzag manner. If you see a wall being constructed and the bricks are being placed, they are never put in one line. You will always find that they are being put in zigzag manner. Similarly here, while taking stitches, we try to put stitches in a zigzag manner so that no raw area is left behind and hematoma formation does not occur. You may have to take many such serial stitches in order to cover the entire raw area anteriorly as well as posteriorly. And when you take stitches, you have to understand how much area is being left behind anteriorly or posteriorly, and depending on that you can take more stitches anteriorly or more stitches posteriorly. Earlier we were using catgut, nowadays we use Vicryl sutures. It may be number 1 or 10 Vicryl sutures on a round body needle. You don't have to use a cutting needle. Every time keep checking the patency of the passage. Now you can see the posterior vaginal wall, you can see the anterior vaginal wall. They are coming nearer to each other. Mind you, tunnel has to be maintained well, otherwise the entire purpose will be lost. And once everything is completed, we remove this catheter. See how both the anterior vaginal wall as well as the posterior vaginal wall are coming nearer to each other. I'm trying to approximate anterior and posterior wall. Still there is some gap. That's the reason we'll continue to take some more stitches.
Are you taking interrupted sutures?
Yeah, these are all interrupted
If
sutures.
the gap is left, there can be little bleeding.
The problem is with the video because the thing is not matching. The frequency has to match. Frequency with her video has to match, you know. Then you'll find video coming quite clean. If you go through YouTube, you'll find it so nicely being shown on YouTube. It's there on my YouTube.
It's clear, sir. You can understand what's being
Approximating the vagina.
beautiful.
I'm going to remove that and resuture it.
But still there is a gap. So probably we will take some more interrupted sutures to obliterate this gap. If the operation is being done under local anesthesia, then you can use xylocaine, which is diluted, as an infiltrating medium. It will serve both the purposes. In that case, there will not be any additional xylocaine required. See here how both the edges, anterior as well as the posterior vaginal edges, have come nearer to each other, and we take interrupted sutures and close it and remove the catheter. And the surgery is over.
Very nice.
Thank you.
Very nice.
Very nice.
You're welcome to ask me any questions.
Sir, if we need, we can take second rectangle also.
What do you mean by second rectangle?
Once you have cut the one portion on the anterior and posterior, secondly, we can also cut the second portion also. If it is more, prolapse is more.
See, it was a case of third degree prolapse, and I have taken the entire suture at entire thing at one go only. Why should you have two? It has to be single, anteriorly as well as posteriorly. You know, in this case, UCL was almost 7 inches, 7 to 8 inches.
And sir also marked with this methylene blue, you know.
Sir, I want to say
was a
that
10.
instead of taking one large, can we take two of 4 inches, or single is better?
No, single is any day better. How can you have two? Because in between the vagina will remain, no, in the center.
Okay. One suture you have to complete.
Can I ask a question, sir?
Yeah, please go ahead.
Sir, one thing I couldn't understand was like you have taken a vaginal flap, which you
Yeah.
have removed, but below that is a bladder bulge. So
Correct.
stitches which you were taking gradually, so exactly in which space we were taking the stitches?
See, you forget one thing. Whenever there is a huge cystocele, rectocele, that means the fascia on top of the bladder becomes markedly thickened. So I go to the fascia.
Okay.
I take the fascia anteriorly, I take the fascia posteriorly and approximate them in a zigzag
right.
manner.
Okay, so that was just the confusion which I was thinking,
no.
because normally we are scared of touching that area.
No, don't worry. It's very thick.
Good evening. Good evening, Doctor. Very wonderfully explained.
Thank you,
I
sir.
just
Thank you.
wanted, can I speak?
Yeah, madam, please.
So what I wanted to say was it is wonderfully done and your video is just beautifully explained. But just I want to know the moment you remove the catheter, how do you ensure that the tunnel is patent or it is maintained?
Because if you really look at it, I have been moving the catheter all the time and from side to side. All the time, whenever I have taken stitches, I have been moving the catheter side to side. And you
That
forget
is-
one thing. Yeah, and you forget one thing. Whenever first stitch was taken, it was everting the vagina.
I understand. So
So
there
when
is no
the catheter is
post-op
everted,
adhesions or anything which can block it?
no, the catheter is removed. No, madam.
No, catheter is removed after that is what I'm saying. Immediately after surgery, when you remove the catheter, we don't, there are no chances of any adhesions or blocking the sites.
No, even if it gets blocked, there is no question of anything coming out from there. No, because
That is there. That
was
is very, very nicely done, sir.
Thank you, madam.
Very
Thank you.
nice. Thank you.
I must have done more than 100 cases under local, and I'm very happy with the results.
It looks like that. Thank you.
Thank you, madam.
Thank you. Thank you, sir.
Thank you, sir.
Deliberation and equally wonderful video. And anybody else who wants to ask sir any questions? Otherwise, we can move to session 3 because Uma madam is already there and she is going to take us further in the journey. Thank you so much, Namaskar Sarogi sir, for your gracious presence.
Thank you, madam.
Dr. Sarogi,
Yeah, madam.
sir, you don't do like that extended colpoperineuropathy with the.
No, it's not required because my incision comes pretty low. That's the reason I don't bother to do it. But in few
But the
cases,
hiatus remain the, I mean, say enlarged hiatus, we are not reducing. If say enlarged hiatus with that.
correct, I do agree. But in that case, your incision will go at little higher level rather than coming low down over the
I-
cervix.
I know.
And in that case, you'll have to do P repair. There is no other alternative.
And sir, when we are closing the hiatus, how anything is going to come out of that hiatus, even if
That-
it is larger?
Madam,
Our purpose is that our
No.
purpose is
Hiatus has to be reduced actually. The hiatus is the opening through which the hernia occurs. If we have a little bit constricted hiatus, it will add to the success rate. Sir is telling like that he is very close to the antroitus. The incision is very close to the automatically, but the hiatus is enlarged. But I need to ask sir, if at all there is a failure, why there will be failure?
Failure, I don't know. Maybe because you are in a great hurry not to approximate them properly. Some hematoma formation occurs, infection occurs, and then it fails.
Okay.
Luckily for me, I never had a case of failure till today. See,
Extreme.
this surgery requires lots of patience, you know. Shanti se karte jao. That's the most important thing.
आप जैसे शांति वाला कौन हो सकता है?
1 घंटे में सर खत्म कर देते हैं. Hardly faster than that, I think.
What is more important is I tell all the surgeons whosoever is doing a vaginal surgery, I tell we talk about patient's bladder bowel empty. I tell even your bladder bowel should be empty and your phone should be switched off. That's the most important thing. If you are in a hurry, you had it then.
So it is applicable to all sorts of surgeries.
That is what I'm saying.
Because you never know when you are going to be in a fix.
Okay, that's a nice.
use.
That is why the elder surgeons were so good because they had minimum distractions.
Correct.
Monica,
I'm not that cool, but let me tell you.
And now surgeons have got Bluetooth in their ears. And they are constantly multitasking.
I
So-
take this opportunity to thank both the organization for giving me this lovely opportunity to present my case of Leafoot surgery. Thanks a lot. Thank you, Monica, for inviting me.
Sir, we are blessed to have you, sir.
Thank you.
Sir, हमें मिली है. Thank you, sir. Thank you so much.
Sir, we should say thank to Monica who gave us the opportunity to interact
Yeah,
with
I
you and
know.
to listen to you.
Very
No,
nice surgeries.
I told you I'm born and brought up in Punjab. So Punjab is like my
Yes.
state, you know. And if
Yeah.
Punjab had to be there, Haryana had to be there.
Yes.
I
So
know.
But it is a really lovely sessions.
thank you. Thank you so much, Nishi ma'am. Thank you. Thank you and
Yeah.
Pranam, sir. And now let us go to session 3. Purva, please start it.
Thank you so much, sir, for the wonderful deliberation. Now moving to our third session, that is modified Shidorkar circulage. We invite Chairperson Dr. Anjali Jain Madam. Madam is presently Secretary of Sonipat OBGY Society. We welcome Dr. Manisha Singhal Madam. Madam is presently Secretary of Karnal OBGY Society. We have with us Dr. Minakshi Rohila Madam. Madam is presently Secretary of Chandigarh OBGY Society. We have with us Dr. Neeraj Yadav Madam. Madam is presently Secretary of Rivari OBGY Society. We have with us Dr. Pushpa Dahiya Madam. Madam is presently President of Rohtak OBGY Society. We have with us Dr. Rashmi Bagga Madam. Madam is presently President of Chandigarh OBGY Society. We have with us Dr. Ritu Goyal Madam. Madam is presently Secretary of Batinda OBGY Society. We have with us Dr. Sangeeta Pahwa Madam. Madam is presently Secretary of Amritsar OBGY Society. We have with us Dr. Sarabjit Kaur Madam. Madam is presently Secretary of Firozpur OBGY Society. Now I hand over the session to our chairpersons to introduce our speaker, Dr. Uma Rani Swan.
Dr. Sangeeta Pahwa, is she there?
Yes, ma'am.
Yeah, Dr. Sangeeta, could you do the honors, please?
Yeah. Good evening, everyone. It's my pleasure to introduce Dr. Uma Rani. Her areas of interest, urogyne and pelvic reconstructive surgeries. Her achievements, organized more than 25 urogynec and vaginal surgeries, live operative workshops at different hospitals in Delhi, being invited from time to time as operating surgeons for FOXY workshops for pelvic surgery, wide experience and expertise in managing life-threatening postpartum hemorrhage. She performed more than 1,000 urogynec surgeries so far. She has won Best Research Paper Award in RCAG conference for the presentation on high uterosacral ligament suspension. She is General Secretary, SOFCD. Over to you, Dr. Uma, ma'am.
Yes. Good evening, everybody. I must extend my sincere thanks to Dr. Monica. And repeatedly, she's telling me these are the gathering are almost the PG students. So you explain everything in detail. So that will be benefited. But I know this circulage operation is a bread and butter, and I think day-to-day surgery for all the obstetrician. So I'll be speaking basically what is new, what modification you can do to make it more success and is more easy. I'm sharing the Can you see?
Yes, madam.
Yes, ma'am.
Can see my screen?
Yes, madam.
Yes,
Please
ma'am.
full screen, madam.
Okay, I'm doing. Is it okay?
Yes, okay, madam. Perfect.
So we'll come to the first slide. Wait 1 minute. Yes. To introduce the topic, cervical circulage or cervical stitch is a well-known surgical procedure carried out during the pregnancy to place a stitch around the cervix, aiming to give a mechanical support to maintain the cervical competency, thereby reducing the risk of second trimester abortion or preterm birth. One minute. It's not moving actually. Why it is not moving?
These are the general problems. That's the reason I sent them all the things earlier. I said, I
Yeah.
don't know how to organize the things.
You are intelligent.
Still,
Uh,
we'll end up with
I
problems.
am able to. Now it is, are you able to see the slide?
Yeah, yeah.
Yeah. The cervical incompetency is the persistent opening in the internal os, both phases of menstrual cycle. We usually have the opening and the first half of the cycle, and due to the progesterone effect, we have a closed internal os. That it may lead to painless spontaneous dilatation of cervix, explaining the product of conception in born in cow. The incident is around very less, 1 to 1.5%, but now it is increasing because of the nutritional status, because of the IVF conception, because of the incidence of malformed uterus and everything. So clinically presented in the second trimester pregnancy failure or rupture membrane with a resultant oligohydramnios. The patient are very high risk for preterm delivery. They have a cervical incompetence. So we can say typical case of the born in cowl is you can see the after expulsion of the total intact sac with the fetus may be moving also for few hours or so. So reason for the cervical incompetency is mostly idiopathic associated with the uterine anomaly. Maybe it's very rare to see nowadays, that is DES exposure to the mother, and the previous cervical trauma is very, very common. Now we are doing electrosurgical cauterization or conization like all this, or tracheography. So the cervical incompetency will be more prevalent. And second, if you have an extreme trimming of the cervix in a case of cervical elongation leading to a prolapse. The previous recurrent abortion, it is definitely a more incident-wise more prone for the further abortion. The previous premature deliveries, multipetal pregnancy because of the pressure, the connective tissue disorder, maybe it is rare, but it is also there in the list. So the diagnosis is usually, we have this very difficult to tell that the fetal fibronephritis detection, nobody does, but it is definite investigation for this. And then ultrasonographically, we usually serial ultrasound to know that the cervical length and the diameter, the internal os diameter is increasing. So the cervical opening at rest, we can see what is the cervix, the length as well as the internal diameter. But when you have a fundal pressure, it can have a wider internal os. There may be bulging of the fetal membrane inside the internal os. It may be TYV or U-shape, the bulging of the membrane. The complete bulging can cause a hourglass type of appearance. The shortening of the cervical and severe case, the fetal parts and the umbilical cord extends through os. Many of us have seen for many times also. So these are the conditions, these are the type of funneling. It may be U-shape, V-shape, Y-shape and everything. So the cervical length and if you see the incident of the cervical length with that of the pregnancy failure, normally it is usually 3 centimeter or more. If it is less than 2.5 millimeter, then the before 24 hours, it may be before 24 weeks of gestation, then the cervical incompetence is likely. The risk of preterm delivery is, if it is less than 2.5, then it's 18%, less than 20 millimeter, it's a 25%, and less than 15, it's a 50%. The cervical funneling, if it is there, the important finding warrants the emergency surclage. The more than 50% funneling before 25 weeks associated with 80% of the preterm delivery or fetal demise. Then the description of the intervention is a cervical surclage is one of the best procedure to prolong pregnancy. The procedure involves the positioning of the permanent suture around the cervix at the level of internal os. It provides a constant resistance over the internal os against the intrauterine pressure. So it can be done in the vaginal or abdominally. Nowadays, abdominal procedure is more prevalent because of the people are more competent in the laparoscopy, but many times it is not required to index operation, but abdominal is confined when there is a recurrent failure of the vaginal procedure. Now people are taking at the first line of treatment is the abdominal surclage. So we are coming to the benefit of the procedure is in women with a single-term pregnancy, insertion of the emergency surclage may delay the birth by average of the 34 days compared to the expectant management. It may also associate with the twofold reduction in the chance of birth before 34 weeks of gestation. However, there are only limited data to support the associated improvement in the neonatal morbidity or mortality. We don't know actually, even if we prolong the cycle, we cannot give a guarantee the baby will be in a better functionally and mental stability. But definitely we believe that even if it prolongs for 1 week also, the fetal outcome will be much better than before. So the indications are many. The history indicated asymptomatic patient with the risk factor, gynecological history, increasing risk of the preterm birth. The woman with 3 or more previous preterm birth is definitely offered the subclass. Ultrasound indication, you said we have already discussed that serial decreasing in the length and width of the internal os, especially before 24 weeks. The routine insertion of a surclass in a history or ultrasound indicated surclass in women with multiple pregnancy is not recommended, but it is up to the domain of the IVF specialist. They usually refer the case with the surclass inside. Yesterday, last night in the emergency, the patient has referred one case with the 32 weeks of gestation. The primary IVF conceived. It has already taken steroid as well as the neuroprotection with the Maxwell. And this patient is severe pre-eclampsia, not having eclampsia, and having hematuria. So in this condition, the patient referred to us. Then there is no history of surclass also. Then we did a cesarean section because we did a ultrasonography. Doctors told us that the liquor is okay. Why you are intervening the patient? Then I talked to the referred patient, doctors. So why you are so much hurry to that? I see that they have not written anything, but when I talked to the consultant, she narrated everything, 1 or 2 she has undergone. She told me that she has twice episodes of SpO2 down and twice episode hematuria, and for that reason, we have completed our homework and sent the patient to you. When I did this cesarean section, I didn't know that this surclass has been put. Then customary sec, I just put my hand to see that the os is open or not. But I know that she's a potential candidate for PPH. For that reason, I do prefer to do a prophylactic uterine artery as well as the descending cervical artery ligation as a index operation to reduce PPH in future. But during intraoperative procedure, there is no bleeding inside the cavity. It was absolutely dry. And then I put my finger to the cervix. I feel some messy, mess. Then I thought it may be surclass has been given. Then I put my Alice corset to hold that, and it, because of the softness, it has come to in my view, and I removed that silk suture. Okay. For that, then I felt this another suture is there. Then I could not able to feel the sutures actually. I left it. I thought after doing the cesarean section, I'll thoroughly survey the cervix again. Then I complete the surgery. Then what happened during my vaginal toileting, I did myself because I am 100% sure that she's not bleeding now. Then without utter surprise, I could not put my index finger. I could put my little finger inside the os, but I could able to feel the clots inside. After 15-20 minutes of the no bleeding. How to remove that? When the cervix is so stenosed, I could not put my finger even with that condition. We cannot do a dilatation of the cervix also. Then I did, I have never done it before, but by feeling, I hold the Alice forceps with the anterior lip, and I put a suction with the Hagar, that suction cannula. Seeing that it is not going to anterior aspect, it has gone to the fundus. I suck out all the clots and put a massage, and then I waited for 15 to 20 minutes. The bleeding was normal, so I left the patient. But you see, with this 5 to 6 months of surclass, the cervix is so stenosed. Even I could not remove the intrauterine clots. That is the plight actually. So it also carries a lot of complications with this. The routine insertion of that rescue surclass, where the cervix is already open and the fetal membrane exposed, we know the rescue. We'll be showing the procedure. The advanced dilation of cervix more than 4 centimeter or membrane prolapse beyond the external os appears to be associated with a high chance of surclass failure. We know that the more the exposure of the membrane to the vaginal vaginal area, the infection is more, the patient may be a prone case for chorioamnitis, which is actually a very dreaded complication for a mother. So we know the high risk and intermediate risk. These are, we have already narrated. The previous preterm birth and second trimester abortion, which is 16 to 34 weeks of gestation, the high risk patient, previous prone, less than 34 weeks of gestation, previous use of surplus, the known uterine variant, history of tracheorrhaphy. And now we are doing also to reduce the volume of the this thing and make the prolapse surgery more successful. Also, we do tracheorrhapy. The woman, which includes that the previous full dilatation also, that is intermediate risk, less. Apart from this high risk, we are all low risk or intermediate risk. So the type of cerclage vaginally we narrate the actually vaginal procedure because majority of us are doing vaginal procedure. With that, we know the conventional method is McDonald cerclage and then the Sirotkar. The McDonald cerclage is a simple bursting sutures technique which around the body of the cervix at the 3 to 4 bites at the lower level of cervix, but usually go as high as the site where actually there is a reflection of the vagina to that of the cervix. So but we are not dissecting anything. We're just putting a permanent suture around the high level of cervix, not in the vagina. But in the Sirotkar cerclage, we have a bladder flap has to be reflected anteriorly to identify the internal loss. Internal loss is identified as a small, around 2 to 3 millimeter reed-like structure. We can feel it when you are going to exocervix. So in that level, our whole motto is to put a cerclage at that level. So it is known as Sirotkar cerclage and selling total the cervical occlusion. Nobody does, but it has got role. When you fail to see that it is not actually giving a full good amount of cervical length, you can have a 1, 2, 3 cerclages at a time also, but it is rare to see. So the external os is closed with continuous Leiden sutures. Cervix mucus plug acts as a mechanical barrier between vagina and uterus. It acts as an innate defense to the cervical canal. Actually, it is of this subject. 2 to 3 months back, there is a patient of cervical pregnancy, and she is a IVF conception, cervical pregnancy, and there is intrauterine pregnancy as well. Okay, so this patient referred, and she was bleeding since 1.5 months, more than that, and every day she is using pad 3-4 pads. And all the time, till date of our referral, the patient has already taken 10 units of blood. This much of bleeding she was, and she is a known case of cervical pregnancy as well as intrauterine pregnancy. This patient is a very, very adamant. The husband is very adamant. She doesn't want to terminate the pregnancy. So we refer the patient to the fetal medicine. The fetal medicine people under the ultrasonography guidance, they put KCL and make the baby non-viable. But the intrauterine pregnancy is continuing. Still, till that, then she continued to bleed for another 1.5 months. And she had total blood transfusion is around 23 units. Then with that, what happened? We cannot do a local suction also. We do not know where we are going. So I put under anesthesia, taking all the risk and everything. We put a cerclage 1 by 1 to compress the cervix. So we have already put 3 bursting cerclage, and it compresses the cervical pregnancy, which is no more viable. So the patient went with that. I think the patient went into 28 weeks of gestation. Then it started bleeding, and we did this thing. The baby was in NICU for 1.5 months, and the baby survived. But see the adamant nature of the father, that the patient has taken more than 30 units of blood total. So this is not actually heroic. These things should not be done by anyone. Now the principle of cerclage. If you go down near the external os, and near the external os, we put a McDonald cerclage, but hold the length, and the internal os is act like a incompetent cervix. So the by rule, this McDonald suture should have a failure, but we know everybody is doing the failure. It is very less. I don't know why. Then you come to Shirodkar subclass, it has gone to the little bit higher, around 2 to 3 centimeter higher than the McDonald subclass. So then you go to the abdominal, so it is almost in the beyond the internal os, that is in the isthmus of the uterus. It is a transabdominal subclass. I will be coming with the abdominal subclass, you see. So anteriorly this is like that, and posteriorly they will put a knot. Either they will put a knot here also, but the target is to proximal to the uterus coil ligament. So indication of the patient to history of failure of vaginal stitch is the indication for the abdominal subclass. It can be placed around 12 weeks of gestation or pre-pregnancy also. Non-pregnancy interval subclass can be given. It can be done laparotomy or laparoscopically. The bladder flap is reflected down. The stitch is passed around the cervix at the level of internal os. The delivery by cesarean section is a must. The time of procedure, usually we have chosen that 12 to 14 weeks because we are confirmed that the baby genetically a okay baby for us, and the emergency subclass, rescue subclass can be done anytime, but not after 28 weeks of gestation. The abdominal subclass, usually 12 to 16 weeks is the preferred time. In cases presenting before 20 weeks, insertion of the emergency subclass is highly likely to prevent preterm birth before 28 weeks. The emergency subclass can rarely be justified beyond 24 weeks of gestation due to the potential risk of iatrogenic membrane rupture of subsequent. But nowadays we are doing beyond 24 weeks as well. The conceptual subclass is it should be considered with the possible because of the anesthesia risk or technical advantage of the operating upon a uterus which is actually non-gravid, who is not a pregnant lady. Furthermore, there is no evidence that the preconceptual transabdominal subclass has any detrimental impact on fertility or care or the treatment of the early miscarriage. So perioperative consideration should be like the woman should be offered a first trimester ultrasonography. Screening should be excluding it's a malformed baby or genetically abnormal baby. Viability is ensured before ultrasonography indication of emergency subclass. It is preferred to ensure an anomaly scan, and regional or general anesthesia is required. Usually, I prefer a regional anesthesia most of the time, and there is no evidence that is. But in the abdominal subclass, we have to go for a general anesthesia. There is no evidence that specific anesthetic has any advantage. The routine catheterization is not required depending upon the anesthetic or surgeon's discretion. The finding is usually typical of this fornelli. When there is external os opening, the internal os also opening. This is the presenting part. So the subclass in a malformed uterus is also feasible. We have a case of Didelphys bicollis. We have put a subclass, but last conference, somebody was discussing about that if there is a asymmetry of the two cervix, then what to do? Then usually it is considered that the symmetrical cervix continue the pregnancy. Asymmetrical cervix is definitely rudimentary sort of. So you put a subclass as high as possible. You may or may not include the non-pregnant cervix. So this is the area we put a subclass on the malformed cervix. And then I'm coming to the procedure which I do the modified Shirodkar subclass. It is nothing but it's a I little bit go vaginally through the level of internal os, which actually the abdominal subclass is put. And I'll be showing the video. Let me see whether it is. Is it playing?
Yes, madam.
Yes. So first of all, we grab the. I'm just telling that usually we put hold the cervix with sponge holder. But nowadays, I put the Alice forceps. Alice is more reliable, and sponge holder usually slips. So repeated holding the cervix is more hazardous than Alice forceps. So Alice forceps, very boldly I can hold the cervix, and then the vasopressin solution can be instilled, and just little massage so that uniform distribution. Then you put a incision to the cervix and the vaginal interface and elevate the vagina over that. Then you remove the pubovaginal ligament towards the vagina, so that you can see that the cleavage is proper. sorry for that repeated that bar, but it is visible. You can see then I am ensuring that I am not at the level of internal loss. Till that time, I just go on dissecting the area. Then I go, once you feel the internal loss reach, you stop there anteriorly. Then instead go to the posterior aspect, put vasopressin solution, and put this bolt clamp or Alice forceps to be applied to the cervico-vaginal junction, and then opening with a scissor. Because it's a gravidusa, all are very, very soft. So little bit care to be adopted, and you separate the vagina away from the cervix. And I usually keep myself extra peritoneal. We separate the cervix away from the vagina. Keep always that we are extra peritoneal, and hold the cervix in the angle, and put your speculum and see the area which as you have already exposed. And this is the number 1 Prolene suture. We passed at the level of internal loss. And once it is visible, you catch hold of it and remove it by rotating manner so that you are not injuring the rest part of the cervix. Then you come to the middle. Give a stay suture at the level of 12 o'clock position of the cervix. And again, it is at the level of internal loss. Then you rotate the needle like this and put it at the 10 o'clock to 8 o'clock position. Push it at the substance of the cervix and go to the posterior aspect. By holding the posterior lip of the cervix, you can see by pressing that you can see the needle coming out of the posterior aspect of the cervix, not in POD exactly, it is extra peritoneal. Then again you put a stay suture at 6 o'clock position and remove that. And because I do not give a marceling tape, I put 2 round up suture over that and around 2 to 3 millimeter proximal to the first one. And here I do not give a stay suture at the 12 and 6 o'clock position. It has come out. Then the 2 ends, you identify the posterior vaginal rent and put and come out as high as possible deep in the pouch of the glass. This, and for that also you feed the suture with the free needle and come out of the vagina as deep as possible so that you can correspond to the internal loss level. Before tying the suture, we have to close 2 rent anterior and posteriorly. For that, you can take Vicryl or catgut, whatever, but usually I take catgut or rapid Vicryl. And keep this tail long so that I put only 1 stitch. I go on purchasing sutures to close the posterior rent. Once I come to the right side, I have interlocking sutures. Then I come back again to the original position, and with that tail, I close the posterior rent. Then I come to the anterior rent. Again, I hold the tail long thread and approximate the 2 edges. Just go on closing that rent, not necessarily watertight closure because it will approximate with each other very early. And once you come to the right side, you come back to the left side. And close the anterior rent also. And this is the final result. Then you tie the suture because it's very high. You have to trace the knot till the deep in the POD. And put 7-8 knots and keep a thread little bit longer so that you can identify while removing the suture. Okay, this is the final results. Come to the modified Shirodkar's. This is surclage with a dilated os. This patient has come with a 3 centimeter dilatation. The procedure is the same. The anterior lip can be identified. The posterior lip is difficult to identify once there is a dilated os. But what we'll do the same. We just hold with the sponge holder, because this width we have to hold the large amount of the cervix. Again, you put up. This is the cervix is dilated actually. The everything is bigger now. So once you remove the pubovaginal fascia out of the cervix is also difficult, but you go on feeling the area, the tough cervix to that of the soft fascia and the vagina. And once you put a rent, because it is now compared to the non-dilated cervix, the length of the external os to that of the internal os is more wide. So once you do that, the same procedure we just do posteriorly also. And put suture as we do routinely. Again, Prolene suture. And put a finger through 2 finger, you can take out the needle because it's already dilated, and be gentle because you can puncture the membrane. Then carefully you can put the same suture at the substance of the cervix and take out the needle posteriorly. Many times you fail to pass the needle. So you can undo your procedure and again try. So it has come to the posterior aspect, you take out this. And again, we put another 1 layer of the suture more. And then the tooth. Then this is the main work we do. We put a Foley's catheter inside, and the Foley's catheter will be, the balloon will be around 4-5 ml or 10 ml balloon. First we put the Foley's catheter, and then it has gone beyond that. Then you inflate the balloon so that you gradually push the membrane up. Once it is under place, then you tie the suture. And then you remove the Foley's catheter. It is already inflated Foley's inside, and then you tie. You feel as if you have not done a good job, but if definitely this patient prolongs their pregnancy. And you close the rent again. Always be careful. It is not difficult to pass sutures and suturing the wound and everything, but you should not go to the intra cervical canal actually. Then come to the lap surclage. This has also been done in our setup. This is a procedure we do when there is a repeated pregnancy failure with a surclage failure. And you put a rent in the broad ligament at the level of uterine insertion. This rent is been made anterior and posterior to identify the 2 broad ligament leaf. And away from the uterus, we will definitely have a non-avascular the area. And then you open the posterior broad ligament. Then you deviate the uterus to one side and put your bowel grasper, and you can make a cut over that tenting area. And once it is there, you dilate the opening so that you can easily see, and you can appreciate the uterine vein. Then you have come to the right, the patient left right side, the same thing. Then your true bond tape. It will come and you just put inside. You go to the substance of the cervix, medial to the vessel, and this rate actually guide you not to injure the vessels, and you can pass this tape posteriorly, and then you come out in the right side of the patient, and over that you can see if the patient, the rent is not wide, then you make wide, and then you take out the needle, and again on the substance of the cervix you put the needle. And cut the suture needle and then tie on the surface of the isthmus. The advantage, disadvantages are many in the vaginal as well as abdominal procedure. So the steps of cerclage are the conventional lithotomy position, warm saline. We do not give betadine solution or the toileting to the patient before or after the surgery. We toilet the area with a high amount of saline, warm saline, and then holding the anterior lip of the cervix, identify the anterior crease and local infiltration is given. Incise the vagina away from the cervix and the bladder advancement. Identify the internal os. Repeat the same step to the posterior aspect. Stray extraperitoneally and pass non-observable sutures in the 5 to 2 o'clock position anti-clockwise, then small but deep bite at 12 o'clock position and come out in the 11 to 7 o'clock position. Take out both free end through the posterior vagina. Tie them at 6 o'clock position over vaginal skin and close the both vaginal incision and trim the cerclage thread. So the advantage of the high cerclage is vaginal approach is safer than abdominal approach and relatively easy. All the risk of the abdominal surgery can be avoided. The fulfilling all the criteria of Sirotker cerclage maintains the maximum length of the cervix, so less incidents of failure. The suitable with any non-observable suture. No chance of uterine handling or unnecessary manipulation. We select number 1 Prolene with 32 to 35 mm needle for its slippery surface and easy maneuverability and the less infective one. The suture remains buried inside the vagina in the full course of its the traveling, except at the knot, which is actually deep in the vagina in the POD. As knot remains outside, the suture removal both elective and in emergency situation is easy and remain as a OPD procedure. The technique overview is choice of suture material should be at the discretion of the surgeon. The suture, they can use any suture. The tape usually preferred, but tape has no superior benefit over the suture. There is no difference between the using 2 foresting sutures. One suture is okay. The insertion of cervical occlusion suture is addition to the primary cerclage is not a routinely recommended. Role of second reinforcing cerclage, no benefit. Study has shown the delivery at earlier the gestational age in case of reinforcing cerclage. The post-op care is always tocolytic, antibiotic, and progesterone supplementation. It should be individualized according to the consultant, and no significant difference has been documented. The cerclage stitch removal, I can say that I must have done more than 30 cases, 32 cases. Not a single person has required a OT or labor room removal of the stitch. We usually remove in the OPD procedure. The transvaginal cervical cerclage should be removed before labor, and usually we do not wait for the 37 weeks. I have already written, but I usually remove at the 34-35 weeks. showing that in an Indian scenario with the pain, patient may not able to know the pain exactly whether she is in labor or not. And second, if she may not come in the emergency hour to remove, so we just put in the end of the prematurity. So you remove it and let the patient go, and she can come with the labor pain. The woman presenting is present in established preterm labor, cervical surplus, the potential trauma to the cervix, a high insertion with a bladder mobilization. Cervical surplus might occasionally require anesthesia for removal. All women with transabdominal surplus require birth by cesarean section, and the abdominal suture may be left in place following birth. The pregnancy of from between 24 to 34 weeks or without evidence of infection or preterm labor, delayed removal of surplus for 48 hours can be considered. So complication may be commonest outcome is the failure due to non-traumatic spillage of the stitch. The cervical injury may be there. If unattended, the expulsion, it can be expelled or during delivery. Cervical stenosis, right now I can say I have seen 3 cases out of 3 cases, but hemorrhage in hemorrhage is less likely in vaginal, but abdominal it can have a hemorrhage because you are holding the vessels of the intrauterine vessels. So from vein is more common than artery. The cervical band, when we surplus band pierces the 2 bifurcation of the uterine artery, the premature rupture of membrane or chorioamnitis also are likely complications. Preterm labor is definitely on your mind, and the morbidity is more in the rescue surplus. Rescue surplus is less success than the elective surplus. The life-threatening complication like uterine rupture or maternal sepsis are very, very less, but can happen. So that is all from my side. Thank you all. Thank you for giving me such a opportunity to tell my work actually. I will stop sharing.
Thank you, ma'am, for very, very nice talk. We really enjoyed. And yes,
thank you, madam. Thank you.
Videos were nice. Madam,
I have a question, ma'am. Uma,
yes.
ma'am.
Yes, please, Juhi. Go ahead,
Madam, I just have a question that you just told me whenever the os is open, what precautions we have to take, because it will be, the membranes will be bulging. As you said that I insert a Foley's approximately.
In case of the 2-3 centimeter, you cannot insert a inflated Foley's. You can introduce your Foley's, then inflate it. Okay, it will reduce
And then
the
dissection has to be done similarly, in a similar fashion.
Dissection is the same. But if it's a 4-5 centimeter, then you inflate the.
It is inevitable.
No, it is also success. If
Acha.
yeah, then you cut down the Foley's, the tip one.
Yes, so that it may not injure the.
Yes, then inflate the balloon around 10 to 15 ml saline. Okay, and put I have not shown you, and put a small nick opening in the proximal part of the balloon. Like you have got the tip, and there is a balloon.
Got it.
The stem will have a one nick. Through that, you can introduce your uterine sound, so that you can make the Foley straight. Otherwise, Foley will like dangling.
Membranes don't rupture, madam, in that case.
You have to do something, madam. By desperation, you have to do that. Then few of the cases they success. Then put the Foley's, put the patient little bit the low down condition and put the Foley's gradually. It will reduce the membrane. Then once it is reduced the membrane, Foley's with an inflated bubble inside the uterus or the cervix. Then you do your suturing. Whatever high, how much high you can go. But
madam, is it possible to dissect since the cervix is effaced so much at that time?
Once reduce
do we get that plane?
Madam, once you reduce the membrane, the cervix will be visible.
Okay.
The rim of the cervix will be visible.
With so much of dilatation, best would be a McDonald's, no, ma'am? How will you do Shirodka?
No, it will, madam. McDonald's mein to the bulge of the membrane will do, and a thrombus will happen.
The bulge,
McDonald's
but
is a failure.
Foley's inflated balloon is a good alternative, viable option for that.
Madam, I also have a few questions. You mentioned about cervical stenosis following the primary cerclage. I have seen cases where the patient has had an IVF pregnancy with a cerclage done by me, and the second pregnancy continued nicely. So
Ma'am,
does the primary cerclage always give rise to some degree of cervical stenosis as a rule?
not always. Nothing is absolute, but definitely I have seen yesterday last night itself. So I can't tell it's not. I could not able to remove the intrauterine clot. You see, my little finger. How can I do this thing? And at the mid of night, actually, it's around 12 o'clock position. 12 o'clock midnight. How I'll tell the ultrasonography will tell and everything. It is not possible. In that way, I feel my control, feeling, and putting a suction. It's really not advisable, but out of desperation.
Sir,
I did it.
madam, Uma madam,
Yeah.
my sir used to do, I think 25 years back, he used to do Shirodkar's operation, surgery and cerclage, and we were the residents. We used to remove those stitches. And many a time we couldn't find the knot because it gets embedded inside the suture which we do. So it becomes quite
Maybe
difficult.
now,
We have to undergo. Hmm.
ma'am, now the sutures are definitely developed in their configuration. You cannot compare 15 years back and now. The sutures are quite visible after 4-5
So
months.
they slip very easily. That means the prolene slips very easily.
Modified Shirodkar cerclage, we are using Marcelin tape or True Bond. True
Yes.
Bond. And
That
they are very easily they are removed. Madam, we are doing modified cerclage because it involves less of posterior dissection. And it is less, it saves time. And I've never seen a, bad outcome, always outcome. Madam, you seem to be so enthusiastic about cerclage. What is your opinion about the progesterone people? There is a very large group of progesterone people who feel that in randomized controlled trials, if you put a group of patients on progesterone vis-a-vis cerclage in the other group, the progesterone people are doing better. The progesterone patients are doing better. What is your take on it?
Madam, the diagnosis is not correct one. You
Yeah.
are not very much this diagnosis is incorrect. Any conservative management can. Okay, if your diagnosis gradually there is the cervix is short and the os is open and everything. How many days you can make the patient lie down? You tell me. It's not progesterone, it's the rest which is actually giving rise to. It's the combination of your tocolytics as well as your rest. But in this case, madam, I guarantee after 7 to 10 days, patient is moving like anything. She is resuming her duty. You can't go with the progesterone supplementation.
I'm also a pro cerclage person, and from my IVF friends, I get a lot of rebuttal that Dr. Monica, why are you so much pro cerclage? Now is the era of progesterone, so this just came to my mind. Ma'am, one more question. In your abdominal cerclage, you mentioned in one slide that you leave the abdominal stitch in place after delivering the baby.
Yes.
Now, suppose this patient goes for the second IVF. Then
it's okay.
Can you do the embryo transfer and everything with the?
It is a exocervix we are serving. The canal is maintained.
There will be no distortion of the canal or nothing, no resistance. Because removing that abdominal cerclage will be an unnecessary exercise, and the patient will have to, go through all that thing again. It makes sense. Yes.
Ma'am, let me tell you that I do extraperitoneal cerclage, but
Yes, ma'am.
Dr. Piley does intraperitoneal cerclage vaginally. He opened up the pouch of Douglas. He went to pelvic cavity over the pouch of Douglas and rotate all the whatever the muscle tape and put a cerclage inside the peritoneal cavity. It doesn't. In that case, like abdominal, you have to in abdominal you have to do a laparotomy. But here you can do a pouch of Douglas. You can open and remove. But many times my procedure is helpful to the you as well as the patient in an emergency dilatation of cervix. But in an intraperitoneal cerclage and abdominal cerclage requires a little bit expertise and laparotomy.
So, madam, I also take help of ultrasound machine in my OT. So when I'm doing a cerclage, the patient is given a little bit of Trendelenburg, reverse Trendelenburg, and I use an ultrasound machine to just visualize the sac whether it is moved up. I usually do cerclage in my IVF twin gestations, which have come down drastically now. We are doing single embryo transfers. The twins have come down, but we visualize with the ultrasound machine. It's shifted up, and then we can confidently put the stitch.
It's a very good tool actually. Our ultrasound guide.
Yeah, yeah.
Monica, I wanted to know, they are postgraduate students also, na?
Yes, sir. Yes, sir.
I wanted to ask them on 2 or 3 questions.
Sir,
First
but
question is,
Sir, please,
first
please, sir.
question is, why mid-trimester abortion occurs in cases of incompetent OS? Why not first trimester? Why not third trimester? We always say, na, mid-trimester abortion occurs in cases of incompetent OS. Second question to them is, when you put a knot, do you put it at anatomical internal loss or you put it at histological internal loss? That is second question.
Between anatomical and histological intervals.
And third question to them is, Shirodkar originally used Marcelin tape or fasciolata. And what was the idea? The idea was, once he has put a knot, he never removed the knot. Either he will do a section or he used to put beads on both the side and cut in between the beads so that cervix opens up. And then what he did was, subsequent pregnancy, if tightening is required, he used to approximate the beads. That was his original idea of doing tightening of horse with Marcelin tape. So you can
how?
ask these questions to.
Yes, sir. So how to put the beads? The beads are still put, sir, by somebody?
Beads are, we are not putting the beads now, but Shirodkar started using beads. What he used to do is, he used to put both the beads on both the sides of midline and cover with the posterior vaginal flap. And whenever it was required, he used to cut between the beads so that cervix opens up and patient can be delivered vaginally. And in next pregnancy, he used to approximate the beads. He doesn't have to take the full suture.
That is so
That
sensible.
was his idea.
I think question
We are
asked-
following him, but he is the innovator. Na? That's the difference between we.
So I think
Now,
our
now I think, Uma,
the questions.
yeah, you can ask the postgraduates. I have no problems.
Yes, sir, postgraduates must
Ask
not
them
be,
what is Reynolds.
they must not
You
be
can
having
ask
the
them what is
name.
Reynolds phenomenon.
Yes, sir.
I didn't know it's phenomenon.
Reynolds phenomenon. If they know that, they will know the answer for the why the incompetent OS causes second trimester abortion.
Yes.
They have to know about Reynolds phenomenon.
Put in our group.
Other thing
the
I'll tell you, when you are using silk or whatever non-absorbable suture material, Uma, if you take Marcelin tape, that means your true bond which is available, it has a thickness or width of almost 3 to 4 millimeters. You understand? It will cover both internal loss. That means it will cover histological as well as anatomical internal loss. That is the biggest advantage. Second, I'll guide you, is use plenty of xylocaine jelly. I apply good amount of xylocaine jelly on this true bond so that it slips easily. Third thing which I do is, I take use of mixture. Create a space on both the sides anteriorly before passing the true bond needles.
Okay.
So it becomes much easier for me to pass the true bond needles. And let me tell you, I must have done more than 100 cases of Shirodkar's original os tightening, and one failure has occurred. Not even 99% of my patients have gone up to term. That is my advice to you all. What is more important is, you should always try and go as high as possible. No need to open the peritoneum. You can go higher up posteriorly as well as anteriorly and tight. There is never a problem in that. So no need to modify Shirodkar's, and I have never taken a stitch in between. You take stitch at 12 o'clock and 6 o'clock. I have never taken a stitch till today whenever I have used Marcelin tape or true bond, because it snugly fits over there and I make it tight. That's all. So that removal also becomes much easier.
Sir, you are using acrylic tape. I'm using a suture. So I'm in a lower category to have a success rate. That is why I put everything in place. But your thing is that the rock with the multi-braided sutures, it doesn't sleep actually.
Madam, true
Yes, that is
bond,
why you used to bond, no?
Madam,
Yes.
true bond is economical as compared to Marcelin tape.
Yes.
Cost of 2 true bonds is equal to 1 Marcelin tape, and you can negotiate also.
Correct.
Yes. And yes, sir, all these suggestions are excellent. Creating the space with mixture, using xylocaine jelly for lubrication, and all
Telling
the
you, I'm so happy using xylocaine jelly. It just slips off.
That's the advantage we have to speak senior to seniors like you, you know. This is the best part of the
Now you can find out the answer from the postgraduates about Reynolds phenomenon and why it causes mid-trimester abortion only.
Raynaud's, so it's vasomotor something, no, madam?
No.
No. Reynolds phenomenon is basically for this. Namaskar, Hara sir.
Sir,
namaskar.
Sir, the Hara sir has to leave for some hospital, so we'll start the session 4. And thank you so much for the nice question answer session, sir. Thank you. So please, Dr. Virul, can you start session 4? Virul, Purva?
Yes, ma'am. Good evening, everyone. Last but not the least, we are at our 4th session, which is on the topic non-decent vaginal hysterectomy. For that, we have wonderful panelists. Chairperson with us. First is Dr. Harsha Shekhawat. She is the secretary at Bhivani Society. We welcome. Next, we have Dr. Jasmine Kaur Dahiya, ma'am. She is secretary at Jalandhar Organic Society. We welcome you, ma'am. Next, we have Dr. Madhu Goyal, ma'am. She is secretary at Kotakpura Faridkot Organic Society. We welcome you, ma'am. Next, we have Dr. Nishi Garg, ma'am. She is director at Garg Multi-Speciality Hospital, Faridkot, and also president. We welcome you, ma'am. Next, we have Dr. Parneet Kaur, ma'am. Ma'am is president at Nabha Organic Society. We welcome you, ma'am. Next, we have Dr. Preet Kanwal Sibia, ma'am. She is secretary at Nabha Organic Society. We welcome you, ma'am. Next, we have Dr. Pritika Nijhara, ma'am. She is secretary at Panipat Organic Society. We welcome you, ma'am. Next, we have Dr. Seema Pashricha, ma'am. Ma'am is president at Jalandhar Organic Society. We welcome you, ma'am. Next, we have Dr. Shubhanjali Sen, ma'am. Ma'am is president at Panipat Organic Society. We welcome you, ma'am. Next, Dr. Snigdha Purana, ma'am. Ma'am is consultant at Director and Well Women Clinic IVF, Sirsa. We welcome you, ma'am. Now, I request our chairperson to introduce our speaker, Dr. Hara Patnaik.
Dr. Nishi, ma'am. Dr. Nishi, ma'am, please, can you do the
Yes. So it is a proud privilege to introduce Dr. Harprasad Patnaik. He's MD, MICOG, FICOG, and FICMCH. He's consultant gynecologist and endoscopic surgeon in Cuttack. He was vice president Foxy 2009, president IMS 2015, secretary general SOFSI, governing council member ICOG 2010 to 12, and national corresponding editor Jogi. So let us listen to Sir on NDVH. Welcome you, sir.
Yes, madam.
Hearty welcome. Hara sir has traveled to Jammu, landed in Jammu, and now he's talking from his hotel. We are so thankful to him.
Great.
Thank you, sir.
And there was a time when NDVH was a very commonly done.
कहाँ से करेंगे? Stop share.
Namaste, sir.
Vineet is here.
Oh, hello, Vineet sir. Namaskar, sir.
Sir, पहले share, फिर ये आ गया. Can you see my slide?
Yes.
Jagannath Bhagwan.
Full screen आया?
नहीं आया sir.
Slide show कर दो. Yes. Visible.
Full screen हो गया?
Yes.
जगन्नाथ भगवान का दर्शन हो गया.
अभी स्लाइड चल रहा है.
जी सर.
स्लाइड चल रहा है.
Perfect sir, perfect.
Okay. पहले तो राजेंद्र सरोगी सर को मेरा प्रणाम. And I see Dr. Susma Chawla over there, and Juhi Agarwal, Uma Rani, Dr. Monica, Dr. Nisi, Dr. Purva, and so many of them. And
really, I got up at 5 o'clock in the morning. I was traveling. And so we have come to Jammu. Me and Bineet has come to Jammu for a urogynec and vaginal surgery workshop tomorrow at Jammu Medical College, arranged by Indian Menopause Society. So I am from my hotel room. Me and Bineet are over here. Anyway, blessings of Lord Jagannath to you all, the great Lord. And I request all of you to join this year's Rath Yatra in this July. Well, this is a common topic, and I will like to take your see, James Johnson in 1825. Those are the era when everything was done by opening the abdomen. So the gynecologists of those days only knew one thing, and they had no idea that a non-descent uterus or a uterus placed in the normal position can be removed vaginally. And they told that we consider extirpation of the uterus not previously protruded or inverted is one of the most cruel and unfeasible operation that ever was projected or executed by the head or hand of the man. They totally disagreed that do not try to pull the uterus down. And this is cruel procedure and unfeasible procedure. So we are very far from discouraging bold or untried operation, but there is a limit beyond which it may not be prudent to go. So they were thinking that you have to pull a non-descent uterus down and giving so much of pain to the patient. So this is not feasible, not prudent. This was year 1825. 150 years later, Saravagi sir, this is the commonest operation, what we called as non-descent vaginal hysterectomy. Today, all the vaginal surgeons are telling that give me any size of uterus, made with 36 weeks, 38 weeks or term size, I will remove it vaginally. I have techniques, I have instruments, I have equipments to do. Little bit of tips and tricks of vaginal hysterectomy. Dr. Monica told me that something about non-descent hysterectomy you should speak, and this is very common, and I have discussed this in many of the forums earlier. So if you are not able to see or hear me in between, you please tell me that you are not listening. So we all know that hysterectomy is the most common operation performed by the gynecologist as well as the surgeon. But surgeons do more of abdominal hysterectomy and laparoscopic hysterectomy. Gynecologists only do vaginal hysterectomy. And they also can do abdominal and laparoscopy as well. This is the second most major surgical procedure in female next to cesarean section, that we all know. 600,000 hysterectomy are done in USA per year. And 10,000 out of women undergo, 30 women of 10,000 in UK, they undergo hysterectomy. You see, by the age of 60, 1/3, 1 in 3 women, they are deprived of uterus. That is an old story. Now, after Save the Uterus campaign, the situation is changed. You know, India being a country of 145 crore population, with half of them are women, the amount of surgery being done by the great vaginal surgeons of India will far outnumber the surgery performed by the entire world, I should say. So Indian statistics say that around 12 to 30 per 1,000 cases are hysterectomy. What is non-descent vaginal hysterectomy? We have done away with the word non-descent. It is vaginal hysterectomy. So it is a surgical removal of a non-prolapsed uterus via naturalis. So we say those 150 years, James Johnson, he was thinking that NDVH is difficult. He has no idea that it is possible because operating in a deep and narrow space, poor visibility in the operating field, almost a blind procedure, difficulty in putting clamps and stitches, and there is no place for the assistant to see inside. Because the head of the surgeon is in the center, the assistant has to put your head this side or that side to cut a stitch or take a bite. So what is the easy one? If the size of the uterus is around 8 to 10 weeks in a multiparous woman, capacious vaginal canal, there is no previous cesarean section or any other abdominal surgery previously, adequate exposure, good light source. So good assistance and good instrument, only clamps and cautery, you do a cake one. And so now that this is the easiest probably for all of us, for all beginners to do it. So when you do a surgery, you need to do a pre-operative planning. Do not just rush in. There must be a pre-feasibility, do a proper assessment, then plan what are you going to do. For any surgery, for that matter, if it is to be done abdominally, do it abdominally. If you think that you will be doing it laparoscopically, do it laparoscopically. And there is a proper indication for vaginal surgery. There should be a genuinity of the indication. The patient must have symptoms for which you are going to do the operation. You assess the patient yourself, examine the patient properly, and there is a role of pre-operative sonography, particularly in locating the fibroids, in locating the adhesions in the anterior surface of the uterus, the position of the myoma, how many are they, where are they, this will be known by preoperative sonography. And if there is a case of previous endometriosis or any other adhesion, there is a need of laparoscopy, do not hesitate to take laparoscopic assistance. Even anesthesia, OT setup and good assistant is a very, very essential thing. Finally, after giving anesthesia, please do an examination under anesthesia. This is a gold standard. And Dr. Sarogi sir will always agree with me that EUA has a rare, and you will be able to do a pelvic examination in a relaxed uterus, muscle is not there, and so that you will be able to, you can pull and see whether there is any puckering, the visibility can be known. So skill development is very, very essential. Sorry. Well, for any surgical procedure, you need to have some technique. And what is technique? This is, you have to adopt a proper hemostasis. And you see, it is very essential that hemostasis to the patient by the surgeon is of prime importance, and oxygen support by the anesthetist. These are the two major indications for complication in the OT table. And the steps must be simplified so that you will be able to do as a beginner. And please remember that do not create a complication and manage it, but rather you do a preventive surgery. If you are expecting adhesion, go accordingly, which I'll be bringing to you. Recognizing the problem and managing it rationally, identifying the surgical limits and patient safety. If you are capable or you feel that you will be able to do not meddle with the procedure at any cost. I will do this large uterus vaginally, taking 2 hours, 2.5 hours, 3 hours with so much of bleeding, no space. Please do not do. Patient safety is of permanent importance and prime importance. So more and more by vaginal route. Again, I come back to hemostasis. See, hemostasis is very, very essential. You see, hemostatic agent, we are very epsiloamin, capric acid was given earlier, now tranexam is taken. But most important thing is that finding the proper tissue plane. If you are in the proper plane, the bleeding will be least, very less. And use of electrosurgical device in a proper way, that will help you a great less. So the step of vaginal hysterectomy, you know, assess the anterior pouch, open the posterior pouch, and once they are opened, then you have to put your clamp. So clamp close to the uterus, there must be parallel, and it should be put on the uterus so that it will slip, but it will remain very close to the uterus. That will prevent injuring ureter or vessels at any cost. So whether you do suture or sutureless, we are very much comfortable doing so many sutureless hysterectomy only. We use a vessel sealing device of Martin or so many you can use, and that is the thing. But most important thing is that you have to debulk the uterus. If the size is big, uterus is not coming out, you have to core it, or you have to use a myoma screw to remove the myoma. I will show you. So in entire operative procedure, you must have adequate tissue respect. Do not meddle unnecessarily, make the patient bleed or do it. And finally, again, I impress upon you the procedure of hemostasis. So any surgery is possible. It will be good if you adopt a good technique. Number one technique in vaginal hysterectomy is debulking and coring. What is debulking? After both the uterine vessels are ligated and they are clamped, the bleeding will be least. So that is the time when, if the uterus is not coming out, you can core, give a vertical incision from fundus to the cervix, then cut in semilunar cut on the uterus and remove it in piecemeal, in crescents, so that the size of the uterus will come down. Second thing, please remember that if the uterus is broad, if you do coring, this will come to the center and size of the uterus will come down and you will be able to deliver. Use of myoma screw is highly important, very much important, because when you find a myoma, you give a cut on it. Once the cut, may be overcut, the myoma will be propping out of the pseudo capsule. Put a myoma screw, fix it properly, pull it. The pseudo capsule will be stretched. Take your scissor, use it as a lever, and on the tip you can deliver the myoma. Say, finding the lateral windows is of importance in a previous cesarean section. What happens in a previous cesarean section? The bladder is adherent to the anterior wall of the uterus in the lower part. So if you are going above, high, or as you go up and up, you will face the bladder, and if you are not careful, you will injure the bladder. But what you see, the peritoneum is attached in the central, in the midline, but it is loose laterally, as told by Dr. Series said. The lateral windows, so approach from the lateral side, come to the center, identify where it is, and you can cut on the uterus and release the bladder, and it will be easy. And finally, my talk on vessel sealing device. What is a vessel sealing device? It is a electrosurgical device, a modified version, and this will seal a vessel effectively up to 7 millimeter diameter. Uterine artery, uterine vessels are of a vessel of 5 millimeter diameter. It will completely coagulate and flux the fibrin content of this, and it gets its close. It is auto stop, auto cut, so that you will get here a beep when the tissue is coagulated and no more current will pass and you can cut. So if you are adopting the technique, what you are thinking earlier as contraindication of vaginal hysterectomy year before has become your indication. And with broadening horizon, we are able to deliver bigger and bigger uteri. Removal of adnexus and other organs, removal of lesion by vaginal hysterectomy route, removal of large myomas. In previous cesarean section, I have already told multiple scar, pelvic endometriosis, and nulliparity. These are the contraindication or relative indication in yesterday year. And once you go with that, then you are able to perform it better. What vessel sealing device, you have already told. This is nothing but an electrical cautery. It has got a wide range of wattage from 50 to 150 watt. It has got 2 monopolar, 2 bipolar. It has got underwater cautery. You can do hysterectomy procedure. You can do laparoscopy procedure. And it is vessel sealing. You use a clamp. The entire clamp is insulated. Only the inner side of the tip is not insulated. So the current passes from one end to the other. Patient plate is not required because the circuit is complete from the tip of the blade. It is auto stop and auto cut. I told you, once this tissue held between this is coagulated, this stops automatically. And its current is cut off, it is auto cut, and it has got 3 fruit pedal, yellow, blue, and black. And this is Martin Maxim, which I am using for so many years. I do not advocate, but there are so many things that are available in the market. Thunderbird, yes, even Alan Kotri has come, Solus has come. So many Indian Kotri as well as foreign Kotris are also there. The one which you are comfortable with is the best one for you. And so that is the machine which will help you. So the so-called barrier of vaginal hysterectomy, scar is it, size is it, or skill is it, is there and you should not. The mental block of the descent, assess, size and adhesion need to be banished from the mind of gynecologist. So with conviction, inclination, perseverance, you will pave the way to do difficult vaginal hysterectomy. So let's discuss about one or two large uterus. See, how big is big, I want to say. Say 14 weeks, 16 weeks, 18 weeks, 20 weeks, 20. How big? The number one point I want to say that the size which you are comfortable with should be your limit. As you go high in the ladder, you can go up, and you have to judge that whether I will take a long time to remove it in piecemeal and bleeding so much without a tissue plane. Is it better for the patient or this toiling is justified? So it depends on your surgical acumen, you will decide. But one thing I want to say you, if the uterus is elongated vertically, volume remaining same, if it is broad laterally, both the uterus have same volume. But one is elongated vertically, the other is broad laterally. The first one is easy to do because you have lateral vaginal space. If it is broad laterally, it is difficult for you to put a clamp. So this becomes a little difficult. Of course, you have to do it. So fibroid uterus, I have already told the position of the fibroid, whether it is in the body or the fundus. You have done a pre-operative mapping by ultrasonograph. So you know the location of the fibroid, whether it is single or multiple. Show that whether it is posterior or anterior. You know, if it is anterior on the body, in the lower part is the easiest one. So I have already told you that cut when you go up, do a hemisection. It is the myoma is popping out. So give a cut on it and pull it with a myoma screw. Previous cesarean section I have already told you about the bladder and lateral windows. One thing I want to say, do not struggle to open the anterior pouch. Cut it, the vaginal mucosa, let it go. Go with your clamps, go with your sutureless or a coagulation and cutting it. As you go up and up, you will be able to see approach through laterally from the lateral vaginal space, and you can see the adhesion in this center with a sharp scissor. No gauze piece to be pushed up. Cut it on the uterus so that bladder will be released. Never try to it because the bladder will be torn. Second thing, the lateral window will always remain as a guide, and sharp dissection is the ideal one. Removal of adnexia, we always say that it is difficult to remove the tubes and ovaries through vaginal route. But the thing is that the principle, as the Dr. Sarvagi sir has many times explained, cut the round ligament. Once you cut the round ligament, you will be seeing the infundibulopelvic ligament in your front. Take a right angle clamp. What to say, Dr. Said's clamp. Even Dr. Piley has a U-shaped clamp, so that you take it, pull the tubes and ovary medially, put the clamp on the infundibulopelvic ligament, then you can cut it. If it is only adherent ovaries and cervix, it will create a problem. Otherwise, you will be able to do. You have to do a little bit of dissection if it is adherent. See, if you are doing a concomitant procedure like gallbladder or appendix, leave the appendix, leave the gallbladder there. Do not try to remove it through your port. You can always deliver to the vaginal orifice, whatever do. Previous surgery, surgery per se, is not a deterrent or for a vaginal hysterectomy. But you see large, costly abdominal scar who will make you afraid of doing this. But the thing is that there may be omental adhesion or adhesion of the gut to the anterior surface, the body or the pouch of Douglas may be. So that is why when you are trying to ligate something, identify the structure. And once you are identified, this is not got an omentum, you can put your clamp or you can use a suture. So excising the adhesion will be the thing. So pelvic endometriosis, particularly grade 3 and grade 4, are of real problem because the anterior pouch is obliterated, the posterior pouch is obliterated. There is a chance that the gut may be pasted to the posterior surface. So there can be chocolate cyst, bilateral tube mass. You can take a laparoscopic assistant. The answer here is that stay close to the uterus. You will be delivering uterus if you go very close to the uterus and cut it and proceed upwards, and the uterus will be delivered. And if there is any problem, you can always do a laparoscopic assistant. You can always convert. See, in early parasomnia, particularly celibacy and all, we find the introitus is very tight. There is a very narrow vaginal space. It is very difficult to enter into this. And in these cases, vessel sealing device is of great help. So this is one I wanted to show. This is a case of vaginal hysterectomy. See, we use adrenaline-rich normal saline and well, I'll go to the video again. Okay. It is not moving, sir. Now?
No, sir, it is not moving after this.
Sir?
It is buffering. There is a buffer.
कितना टाइम लगेगा? 2 मिनट.
Sir,
अच्छा.
are you using data or
Yes,
Wi-Fi?
madam.
Sir, are you using data or are you using Wi-Fi?
No. We have Wi-Fi, sir.
Okay.
It is not moving, sir. सर एक काम करते हैं. I will वीडियो डायरेक्टली चलाते हैं. शेयर में जाके शेयर चला गया. ये how to share it. Is it running? Are you able to see it?
No, sir. We can just see the screen where multiple videos are there. It has not been selected.
Okay. Vinit?
Yes. Now, yes,
थोड़ा
sir. Video is
yes. Is the video visible?
Yes, sir.
Visible?
Yes, sir. Yes, sir.
Is it running?
It's running.
Same thing is happening, sir.
Same thing. It's going in a loop. The same.
Is it seen?
Yes. This one is running.
Running.
This one is running.
Yes. Yes. So we use, so it is showing that your internet connection is unstable. So this is the Jammu because the only BSNL runs and nothing else runs. Yes, this is cervical vesical ligament. I have given transverse incision. say on the anterior lip of the cervix, 1 inch above the external os, and catch hold of this. We infiltrate adrenalis in normal saline. You see, we open the anterior pouch and posterior pouch with a bolt cord. If it does not come, you do not worry, you can go with the procedure. See, always, and this is the blue color one is the clamp, which we called a Marr clamp. You see, this is blue color because it is insulated from one end to the other, and the current passes from the handle and goes to the one pole, the positive pole, and the tissue head in between is coagulated, and this you can cut it. What happens once it is coagulated? Once it is coagulated, so एक minute, I can. Once it is coagulated, this becomes whitish in color, and they will give a sound beep and make a sound. Then this will stop automatically, which is called auto cut and auto stop. If you press the pedal after that, it will not, current will not flow, no further current. And once you can see the tissue is properly coagulated, there will be no bleeding. You can cut it very nicely. There is no need of putting any suture, any stitch, or a needle holder has to be used, or things like that. So, and if you can increase the wattage on this. So the wattage is up to your choice. You can do it. So if the wattage is more, this will be burned too fast, and there will be a lot of carbonization and blackishness will come. And if you lower the wattage, it will take a long time to be cooked. So you have to adjust your wattage as per your requirement, and you can proceed with this. See, this is this is a non-descent uterus. The first thing, you are holding the lateral cervical or transverse cervical ligament, and so, and we do not use any gauze or muff. We always use suction, microtip suction. So, and you see that it generates a lot of heat. So once, because of the heat, there is a chance of the spread of the heat to 4 to 7 millimeter, and that is why stay away from the lateral vaginal wall, because it's the first victim of a Martin cautery being used tangentially if not applied. So then what happens? So when this is done, you proceed with the, and as you go up and up, you can see that both the uterine pedicle are coagulated. Now you are doing a hemisection. See that the myoma is popping up, and once it has come out, then what you do, you can cut it further and see another myoma over there. See, this is another myoma, and I have already saw this on ultrasonography the previous day, so that once the bleeding is totally stopped because of this, and myoma screw, if it is properly being used, so that you will cut on the myoma, and this will very slowly come out of it. You can see this on the, there are multiple myoma over there. This small myoma, I am leaving to it, and that gradually as you go on up and up, you can see that still then the posteriorly there is a lot of tissue, and it is not allowing the uterus to come out. So we can another myoma and another myoma screw over there and cut it over this, and once you see this, the size of the uterus comes down. We deliver the uterus by posterior approach. You can see the fundus over here, and this is actually the machine, the monitor on which you are seeing that this is written seal safe mode, and these are the current, this is the wattage you can fix. You can also program it on your name, so that your wattage and your expertise will be seen on it. See, now the uterus has been delivered, and the upper pedicle is being coagulated. This is a time when you do not try to pull the uterus because it will give way, it will be torn, there will be bleeding. So once you are coagulating it, please remember that this is a time when you will be likely to touch the momentum or the gut. So put a sponge holding gauze on the sponge and push it so that the gut of momentum will be away from it. And so you can see that they are far away. You have taken the uterus to the center and this tissue is properly coagulated, and you can always see that that has been done. Now that before leaving this, you see the pedicles, try to pull it with the Alice tissue forceps and put another clamp if necessary, coagulate the contents, coagulate the pedicle, sprinkle cold water onto it, then you can leave it like this. And this is the specimen of the after surgery, and the myomas. And what we do now, the suture has to be given from one end to the other. We always give this to close the vault, and we take a bite of the uterosacral ligament along with the lateral when we are closing the lateral end, and we finish the procedure from one end to the other and keep the middle part open so that if any collection or anything else will come out of it. So I can show you another video and the procedure is same, or we can take the discussion while I am going through another procedure. Madam, we can have our question and answer if at all it is required. And I stop here. And
so absolutely wonderful video of a very difficult case.
Madam, there is a collection, whatever is there. I wanted to show you there are so many other videos as well. We can also discuss, but because of time constraint, is 8:30. So
it's always pleasure to watch you, sir. It is always pleasure to watch.
We'll give one
Thank
webinar on NDVH. on
Yes.
VH. On VH, not NDVH.
VH.
It is a
I think we
forgotten
stick to
art,
the-
Monica Didi. We need to keep this.
Yes. Juhi, you will coordinate it again. आपको
Yes, madam, vaginal hysterectomy is the preferred route of removal today. So, and for me, vessel sealing device is a boon. It helps difficult situations like lack of space, lateral vaginal area, and large uteri. The technique of auto stop, auto cut, and vessel sealing makes the surgery really easy. And avoid thermal injury at all cost. Retract the lateral vaginal wall. When we are leaving the pedicles, sprinkle cold water to this. Surgical comfort is most essential. Avoid difficult vaginal surgery from the beginning. Avoid ego and dogma. If you find difficulty, you can always, there is no problem, you can always convert, or you can take help of a senior or an expert. Training, experience, and expertise matters. Size of the uterus is immaterial if you can do it. So go up and up with the size, and with smaller cases, simpler cases to go to difficult case. And vessel sealing device is my boon, and laparoscopic assistance whenever necessary. Correct decision for surgery is mandatory. If you take a wrong decision, it will have a problem. So NDVH made easy. Once Dr. P.C. Mahapatra told me, I asked him how big a uterus you can deliver. He told if a 3.5 kg baby can be delivered vaginally, why can't a 36 size, weak size uterus can be removed similarly? Well, sky is the limit. We can always discuss. New gadgets have come up, and you can vaporize the uterus, and you can always say this. Thank you very much for the patient hearing and giving me this chance. And I stop here. And
Sir,
thank you very
I wish we could have given you standing ovation, but we
much.
we
Madam,
very
the great teacher, Dr. Rajendra Sarogi is amongst us. We respect him, we are regard, and sir is really a teacher, and he shows us the path. Beneath is here. He is with Sarogi
Sir, all of you, sir, stalwarts.
Good evening, sir. Jammu is blessed with both of you today.
Thank you very much.
City of Temples, Jammu.
Sir,
Yes, thank
sir, you have given impetus to us again to do NDVH. We used to do in
Juhi has
2010,
started
12.
doing, and
Yes.
she has become a master. And you please do. We are always moving around, and we can always
Yes,
come to you
yes, sir.
anytime.
Thank you
Yes,
very
sir.
much, sir. Thank you very much.
There is a food
Yes,
waiting at Dr. Sudha's place.
using sutures at all? Hara sir?
Dr. Sudha is treating us with food. So,
I have to rush.
खाना ठंडा हो जाएगा.
So congratulations. All
Madam,
the best to you.
Thank you, madam. Thank you.
Thank you, sir. And so we deliver the vote of thanks, and we thank all our dignitaries from Punjab, Haryana, all our guests, my dear Sushma Chawla ma'am, all my speakers, Hara sir, Uma madam, Shrikala
Where
ma'am,
is Umarani? She has left.
and respected Saraugi sir. Today we have had a wealth of knowledge on us, and Synergy will always be indebted to you, sir, for the amount of knowledge which you have given to us today. And for benefit of all postgraduates, you can watch these videos again on YouTube. I'll be sharing the link. Till our next webinar, Synergy 31, please look out for our announcements. Signing off with my team. Thank you to Team Intas, and thank you to our team of doctors, Dr. Vishal Dave, Dr. Juhi, Dr. Purva, and Dr. Viral. Good night to you all.
Thank you, Dr. Monica. Good night. Good night, sir.
Good night. Good night.
Namaskar.
Namaskar. Namaskar. Good.
Saraugi sir, all good night, sir.
Good night. Good night. Good night.
Good night.
Sushma ma'am. Good night, Nishi ma'am.
Good night. Good night. Sushma ma'am, good night.
Good night. Good night. Good night. Lovely to see all of you.
Yes, same here.
Good. So you are coming to Ludhiana?
Yes, yes.
So we'll meet you there also.
Yes, we'll meet there.
Okay, bye.
Okay, bye. Bye.
Most sincere today, sincere listener, most attentive.
But it was nice listening. Very nice.
Support team, please end the meeting.
Thank you. Good night again. Bye.
Good night.